We have Member Merman.
I just saw him.
I see him. Great. And Ms. Barabee.
I'm here.
Great. Okay. I'll call to order our afternoon meeting of May 22nd, 2024. We have a distinguished group of national healthcare policy experts to provide us information on value-based care and the AHEAD model. And I'll turn it to Director Barabee to introduce the panelists and to lead the discussion. Thank you all for being here very, very much.
Great. Thank you. So I'll be brief because I want to spend most of the time allowing our panelists to impart their wisdom and leave time for questions. But I did want to set the stage briefly. So as you know, Vermont, like many states, continues to struggle to provide high quality, accessible, and affordable care to its entire population. And while there are no doubt been significant investments in healthcare and great efforts by many to advance healthcare reform, there's still much work to be done. Vermont has been long at the forefront and has been looked to as a leader in healthcare reform. However, at the same time, we continue to be among the most expensive states for healthcare, and in many parts of our state struggle with access to essential services, especially in some of our most rural communities. So as you know, we're currently discussing with our partners at the Agency of Human Services, as well as providers across the continuum of care and many other stakeholders, including the public, where and how Vermont will move forward in its payment and delivery system reform efforts, and that work is still taking shape. So we've invited this panel of esteemed experts to share their lessons learned, either from their direct experience advancing payment and delivery system reform in other states, or working within a delivery system, or from their academic research. So it's imperative that we hear from many voices as we continue to evaluate options available to Vermont in its next chapter to improve health and affordability of healthcare for Vermonters. So I want, I'll turn it over to each of the panelists to introduce themselves and provide a short bio. But I wanted to welcome Carrie Kalla, a professor from the Dartmouth Institute, Bruce Hammery of Oliver Wyman, William Henderson, our Principal Deputy Director from Maryland's Healthcare Cost Review Commission, overseeing medical economics and data analysis, Janice Walters, Executive Director from Rural Health Redesign Center, who also led the implementation of the Pennsylvania Rural Health Model, as well as Robert Murray, President of Global Health Payment, who previously was the Executive Director at Maryland's Health Services Cost Review Commission. So a lot of folks with a lot of expertise, and we're excited. So I will pass the baton first to Carrie, and we'll kind of go in order. Thank you.
Sure. I get the prerogative of having the first last name in the alphabet potentially. So hello, thanks so much for having me. As Lena mentioned, I'm an economist and a professor at the Dartmouth Institute for Health Policy and Clinical Practice at Dartmouth College. I've recently returned to Dartmouth after working at the Congressional Budget Office for the past few years in Washington. And so I had some catching up to do on the current state of Vermont's planning. But I first wanted to say how impressed I've been by the thought, the care, the analytics, and the approach that you've all taken, the Agency of Human Services and the Green Mountain Care Board, toward approaching this problem. As a researcher in payment and delivery system reform and rural healthcare, and a former advisor to the Center for Medicare and Medicaid Innovation, it's amazing to me to see how much you've accomplished in terms of analysis and planning and what you're considering now. So my understanding of kind of our role here today is that you're gathering as much information as possible now to be able to make a well-informed decision once you have the results and the additional parameters from CMS. Does that sound right? Okay, I just wanted to get you all to interact a little bit. Thanks. So I'll start by saying that it's my belief that payment reform is a necessary but not sufficient condition to achieve the healthcare system transformation you're striving for. So what do I mean by this? If you were to start from scratch and design a new payment system today, you wouldn't magically have system transformation in the short run, obviously. So that is to say, other factors are also necessary catalysts to achieve your desired outcome. But without changing the way we pay for healthcare today, I don't believe we can achieve the transformation and financial stability Vermonters and our providers are looking for. So key things are definitely going right for Vermonters in the health space. Yet, as you're aware, the status quo has myriad challenges that must be addressed. Some of the problems I'm aware of include inadequate workforce and staffing, transportation infrastructure, delivery system financial instability, affordability for patients, access to essential services, among others. It's clear to me that the AHEAD program on its own will not solve all of these problems. Additional leadership will be needed to make the services needed align with patient demand in these areas. So because I'm kind of a payment incentive nerd, I thought I'd start with how do we get to where we are today? And many of you know this, but Medicare's payment design to support rural healthcare has in part shaped the landscape of services and the financial situation facing us today. We have a poor distribution of essential services, which I think of as like primary care, behavioral health, maternity care, and emergency and long-term care services. The federal government historically supported rural health through a patchwork of payment mechanisms, but most of that money flowed through these add-on payments for critical access hospitals, Medicare dependent hospitals, low volume adjustments, sole community hospital, like all these different designations made up a patchwork of ways we added on rural payments. But all of these rely on inpatient care for the most part. Critical access is a little bit of an exception, and in particular, fee-for-service Medicare beneficiary stays. Yet the payment world has changed, the healthcare world has changed since these policies were enacted. And these financing mechanisms are no longer either optimal or sustainable way to support rural residents and maintain essential health services for them. Rural hospitals are financially vulnerable today due to reductions in inpatient stays and increases in Medicare Advantage, which is my understanding Medicare Advantage makes up about 40% of the Medicare market share in Vermont, but because of the patients who are selecting into the Medicare Advantage programs and those payment mechanisms I mentioned, it's a much smaller share of the spending, about a quarter of the share of fee-for-service Medicare spending. I also believe that about 9 out of your 14 hospitals are operating in the red, and that Vermont now has the 4th highest percentage of rural hospitals operating in a loss in the country, like the 4th highest state. So changes in information technology, clinical technology, cybersecurity, reporting, and analytics have changed the landscape for independent hospitals and make it difficult or impossible now for small hospitals to survive. So we need to change the payment environment in order to address the needs of our providers and patients today. Modern care teams include community health workers, patient navigators, and behavioral health specialists, and fee-for-service has proven inadequate to support this needed team-based care. Many in our US Congress and in the Center for Medicare and Medicaid Services recognize the status quo is not optimal or sustainable in terms of supporting rural healthcare, and some changes have begun. The recent addition of the Rural Emergency Hospital designation and recent increases in payment for rural health clinics are to name a few. But further financing changes are likely to take a couple more years, at least. OneCare has set Vermont on a path to payment reform through its focus on total cost of care. The AHEAD model's objectives are well aligned with the blueprint and Vermont's needs now, including a long-term commitment to predictable prospective financial flows through global budgets that account for social and medical risks of Vermonters, money for infrastructure, the continuation of waivers, continued investments in primary care, and support for connections to community resources, which I know are important. I teach classes on payment incentive and incentive design, and you and I all know that it's very difficult to get them right. Last week at the provider meeting, there were many comments referring to the complexity of the AHEAD model. And so I just felt the need to remind everyone of the complexity of the current status quo. Fee-for-service is incredibly complex. I suppose it's the devil you know versus the devil you don't. But the place we are in today is one of these incremental changes resulting in a patchwork of payment programs. And it's a mess of misaligned incentives. I too am concerned with introducing further complexity, but I just want to note that we're not moving forward from like a point of elegant simplicity today. A couple of other things just to think about from a payment design perspective as you discuss how to proceed. What are the potential for unintended consequences? How will incentives created in the AHEAD program interact with other payment policies already in place, and particularly if not all payers or providers participate? And is there any possibility for strategic behavior under the new scheme? So changes in payment are inherently risky. Last week, the providers also mentioned that there's little room for error that exists in the upcoming design. But under the status quo, it will continue to be difficult for Vermont hospitals to get to a stable financial model while also balancing the need for affordability in the state. At the end of the last week's session, your chair asked whether transformation is possible without Medicare as a payment reform partner. I believe the answer is no. I believe the AHEAD program presents a much needed opportunity to change the way hospitals do business in Vermont. The counterfactual, what will happen without participation in the AHEAD program is difficult to predict right now. But he also mentioned the loss of waivers and additional payments supporting things like the Blueprint, primary care, the SASH program, and other programs would be very difficult. Certainly, the AHEAD program is risky in itself, especially so if the commitment by providers and other payers does not come to fruition. Additional work and investment will continue to be needed on Vermont's healthcare workforce in particular, and on maintaining access to these essential services. But if creating a sustainable healthcare delivery system is a primary goal for Vermont, I see the AHEAD program as one way to partner with two of the largest payers, Medicare and Medicaid, to work on it. So thanks. I'll pass it to someone else and happy to answer questions.
Great. And I think what we'll do is we'll have each of the panelists kind of go, and then we can open it up for broader discussion. So I'll pass it over to Dr. Bruce Hammery, if you're ready to go next.
Well, good afternoon, and thank you for the invitation. My name's Bruce Hammery. I trained as an adult infectious disease person many years ago. Spent 22 years in academic medicine and 17 helping to run a large health system called Geisinger. And I have been 10 years with Oliver Wyman as a partner and the chief medical officer. I've had the opportunity and the pleasure to be engaged for the last 9 months in a program to assess and make recommendations around improving all those things that were just mentioned: access, affordability, equity, financial stability of hospitals, and look at the way care is delivered in the community and what happens to people before and after they are either seen in the emergency room or in the hospital. Certainly the data that we have seen and gathered from hospitals supports the view that with the current trajectories of payment and expense, there will be many hospitals in serious financial trouble, more serious financial trouble than they are now. The concern I have, and I'm going to try to share a screen. I have a couple of slides that dear here, where are we? I have a couple of slides that would, oh, wait a minute, wrong one. A couple of slides that would be helpful in doing this. One reflects the population trends that we are experiencing in Vermont. And I think, as you know, Vermont has the dubious privilege of being one of the oldest, if not with West Virginia, having the most rapidly aging population in the U.S. And that clearly has implications for the direction of both federal payments, but also a fairly dramatic decline in the population of young folk who are going to have to pay for, through commercial premiums, any differences between the amounts paid by the governmental payers. So that's one point. I agree with the comment. There is a serious shortage of health professional workforce across all levels. And that shortage will not be alleviated likely in the next 10 years. So it is something that has to be coped with rather than worked around, if you will. Here we go. Can you see this screen? Okay. So this basically shows the change in population, and this is by hospital service area. Service areas defined as those zip codes where 51% of the residents seek care at a hospital. So it's not outpatient focused. And you see the dramatic the decline in population everywhere except Burlington. The hospital, if you look at hospital coverage by virtue of a radius around the hospital rather than a specific service area, you note the overlap. And so one of the considerations about hospital sustainability and, in fact, delivery of outpatient services is whether some of that can be regionalized. And those analyses are going on now. I will just call to your attention the fact, as we think about clinical care and population health management, that we have that classic 5% that accounts for the majority of healthcare expense. I would note that activities aimed at this high risk, the aged, infirm, with multiple medical conditions, as well as often mental health issues, and increasingly in many areas of the country, substance abuse disorder, that those efforts currently in the state are not well coordinated or targeted by anybody. There are specific programs aimed, for example, at substance use disorder and maternal child health, where there are attempts to do this, but in many instances not. Certainly, the data, as we'll talk in a minute, available, which would need to be used to predict and evaluate and identify, is not commonly available. This is one way of looking at the hierarchy, if you will, of healthcare needs. And most of it, as was said, should be able to be provided at a community and primary care level. Following that would be a group who needs help, whether it is help with coping with behavioral or mental health issues or infirmity and assisted living. Home health can be part of that. Next would be the institutional care. And then you really get to primary care. Urgent care, specialty care are more specialized. There is a problem in Vermont and has been with access to these services as well as to primary care. And you see down below the emergency room, and at each of these levels, it's sort of a filter, right? The folks whose needs can't be met at that level fall down to the wind up in the emergency room, which has the issue of identifying appropriate care, whether that's back to the community, and there are delays even in arranging for home health services, or it is to another institution, or it is to a hospital admission. And then, of course, the community hospital and the referral hospital. When you constrain capacity, which is currently the case in Vermont, you push that stuff down. and it results in higher levels of emergency room use, which could be preventable, certainly in higher use in the community care hospitals, and an increase in what are called in medicine boarders, that is, people who are on an inpatient ward in the hospital or on a stretcher in the emergency room for some period of time, waiting for placement in a different appropriate level of care. And this also squeezes the financial parameters, which are shown here. So this is data from the state healthcare budget from one of the state agencies. And it basically shows the large proportion of care done in hospitals, contrasted with the much smaller rates of investment or pay for the community prevention activities and primary care. Last, I'll just mention, based on literature and a fair amount of experience, both in my administrative roles and consulting roles at helping health systems and some other countries redesign their healthcare programs. One of the essential features, as was mentioned, is incentives that are necessary but not sufficient. And we'll talk about the other necessary components in a minute. But it's key that the financial incentives are aligned among all the participants. So, for example, the primary care people need to be strongly incented to maintain access and to, where possible, prevent the progression of illness to the point where somebody needs to be seen in an emergency room or a hospital. And so very organized programs that rely mainly on people other than physicians to do this with protocols, and payments that are sufficient to get people's attention. So 1%, 5% is not enough. And this is one of those things that I think will need careful consideration as the AHEAD model is constructed. Second is that in order to take care of people, you have to know what they have, what's being done about it, and where they are. And that means timely clinical information, and then some periodic financial performance data so that people can correct their behavior in real time, not a reconciliation 6 months after the end of a fiscal year, but real-time data that and actually real-time actionable information based on data. Adequate resources for the community-based services need to be available. I know that this is a principal effort for the Blueprint on Health and a number of the state programs. And to the degree possible, these need to be facilitated and advanced. Availability of referrals to specialists, again, major roadblock. Time periods of anywhere from 3 to 18 months to see a specialist about a problem. Now, I would note that a number of these problems are because the primary care folks don't handle often a headache. And when the specialist sees them and tries to refer them back, they may not have capacity to take that patient back, which then plugs up the specialty clinics. Availability of appropriate levels of care other than inpatient beds. Mental health facilities are tight, being expanded. Extended care facilities have closed because they can't afford to pay nurses. and then the ability of tertiary and other referral patients facilities to accept patient transfers. And clearly, this is an issue as one thinks about rural emergency hospital designation, because it affects not only the transfer protocols, the ability to have those contracts, but also the length of stay that the rural emergency hospitals and current critical access hospitals are expected to meet. And then last, and very important in Vermont and a number of other places, is the availability of transportation to take a sick patient from an emergency room to a larger hospital that would have an appropriate level of care. And this is, again, a large problem. It relates in part to the volunteer nature of the services and in large part to the decentralization of these activities. There are, if I remember correctly, 69 separate EMS services with a varying ability to really transport people. So these would be the conditions, in my view and experience, that are really needed to construct and have a successful population-based payment. And one of the concerns that I have, without having had the more detail in the HEAD model shared, is whether hospital-based payments, when hospitals don't control primary care networks, control ambulances, and the ability of downstream, the capacity of downstream facilities and other services to take care of the patients who don't need hospital or emergency room care, when those things exist, is a question that I'm sure we'll be able to discuss. So thank you for allowing me to show some things, and look forward to the discussion.
Thank you, Bruce. I will turn over to Janice Walters. Thank you.
Thank you. First, thank you for allowing me to be part of this very important conversation. So for those of you who do not know me, I'm Janice Walters. I've been serving first as the Chief Operating Officer here at the Rural Health Redesign Center, and more recently it's Executive Director, but really leading the work of the Pennsylvania Rural Health Model since 2018. So prior to that, I was a former rural hospital leader. I spent 10 years helping to run a critical access hospital here in the state of Pennsylvania. We served a 4-county area, had 10 rural health clinics. So I approach this work very much through, I would say, the operational lens. I was able to spend a little bit of time working for a large integrated delivery network here in the center part of Pennsylvania after having moved out of the rural community for about 1.5 years. And that really gave me an appreciation for the payer community. So where I sit in this work is really, I say, the convener. As the Rural Health Redesign Center, we work with our hospital, much like the Green Mountain Care Board, but with a little bit different governance structure. We sit here and work. I lead the work between the hospitals, the payers, the state government, and then other partners such as hospital associations and vendor partners and all of that. So I view ourselves as the convener of all of the parties that are required to do work such as the Pennsylvania Rural Health Model and the AHEAD framework. I also think it's important to know I'm not a lifelong healthcare career professional. So I also bring to this work I would say an industry lens from 2 other industries. So prior to healthcare, I actually did manufacturing for about 7 years. And then I was in the communications industry, helping to do accounting and all of that for a large communications company. And so it really allows me to bring a different lens to healthcare. And so I entered healthcare right before the Affordable Care Act, right before value-based became, I would say the terms of the day. And I can tell you, entering healthcare It is an archaic system, unlike my experience in any other industry. And I can share a little bit more about that later, and how I think we need to use some of the other industry principles within the healthcare environment if we're actually going to solve some of these problems moving into the future. I actually fell into healthcare. As is very common in rural communities, people, when I watched all other industry leave, the communications company that I worked for actually was part of one of the companies back in the early 2000s. All the scandals, the Enrons of the day. I actually worked for one of those companies, saw it spiral into bankruptcy, and entered healthcare when there really was no other jobs left in the community. And so it wasn't all that glamorous. It was, hey, you're willing to still drive to Coudersport for work? And my response was, what's the job? And so my pathway into healthcare was not glamorous. So as I sit here today, I count it a privilege to lead such significant work as it relates to rural health payment reform. And as I've already touched upon, because I have that diverse background, I think I do bring, a lot of how I approach my work is using basic business principles within a macro system framework. And recognizing that the hospital, the health system is part of a much broader macro system that needs to work together. And that's the thought process that really guides a lot of my work. And I also would describe myself as a pretty pragmatic person in terms of how to take concepts from folks like Carrie, the researchers out there all doing all of this work, but then how to take that from concept to reality, really operations and implementation, I would say, is where my strengths lie. So I've had the pleasure of getting to know a number of you. I see familiar faces on this call, and so it's great to see familiar faces. And I've got to know many of you over the last couple of years, especially in the height of the pandemic, having calls from the various states of, hey, what are you doing, as it relates to your program in the midst of the pandemic. But as I've got to know all of you, understanding where you're at on your journey, a couple of things came to mind based on, the questions and what we were asked to present as part of this portion of the agenda is, our thoughts for Vermont based on the lens of experience that I bring, which is really, running the Pennsylvania Rural Health Model, administrating a global budget framework in a rural setting. And so understanding where you've been, and now where you're trying to migrate to, one of the things, and some of this, for the folks that have heard me or have engaged with me before, you will hear some of the same things repeated, but from a Medicare perspective, you really are going into this from a point of strength. You've already been able to achieve a lot from a Medicare, cost per beneficiary, thinking about the starting point. And, my encouragement to you is if you do pursue an AHEAD program, you really need to leverage that. Especially given, the overarching goals of the AHEAD program is really cost savings. And so, that would be my first. And again, I'll add a little bit more to that through the lens of my experience. But leveraging your strong position really has to be first and foremost, as well as I think being able to define a couple of things. And so I've heard affordability mentioned. I know as I've engaged with you, Carrie used it in part of her statements. I think Bruce might have mentioned it in his, but affordability, it's like, how is that defined, and when will you know if you've achieved it? So I think it's really important to be able to identify the end. As we're developing programs, it's like, what are we looking to achieve? And is this the right tool to help us get there? And so I've heard that term affordability. What does it actually mean? For whom? And how will you know when you arrive there? Much to the point that Bruce just made, one of the things that concerns me as I look at AHEAD too, and again, lessons learned on our journey, as well as now what I'm hearing from my payer community is, as we, like you, are figuring out what comes next. We're very much in that same situation, but the global budget is for the hospital. But we know there's a continuum of care. And so how are we going to align this whole continuum of care? The focus is on the hospital because that's where a lot of the dollar is spent. But ensuring that you have that incentive there across. So what is the incentive for the primary care provider to stay open past 5 o'clock and not send people to the emergency room. And again, you've had your ACO infrastructure in place for a while now, so you might be further ahead on some of this than other states. But again, aligning that incentive to make sure that it really is, it's the continuum. And as Bruce has already said too, real-time actionable data. I mean, that's one of the things that we don't in Pennsylvania have the robust infrastructure that you do. So, we've had to build some of that, but even our hospitals are saying today, every bit of data I get is old. And so we're trying to chase an actionable, real-time actionable data, to manage patient populations and all of that. So they would be my opening, remarks as it relates to, high-level things to consider, but would like to share with you why, like what's informed some of that from my lens. So, again, AHEAD, the work that AHEAD is trying to achieve is really tackle the cost, get cost under control, and a global budget could be a mechanism to do that. But for us in Pennsylvania, again, rural was our mission. Rural is still my passion. Is our initial goal within our program was the sustainability of rural hospitals, which I do believe we achieved, as evidenced by improved operating margins. Improving the health of rural populations. That was our second, I would say, stool to the three-legged stool. And I think we've done that as evidenced by good performance on our statewide measures. And then reducing the total cost of care, again, as evidenced by we're well within our total cost of care guardrails. CMMI will tell you what we didn't achieve as hospital savings. And I know we have colleagues here from Maryland. Some of my contract was actually inherited from Maryland's contract, and we started at very different points on our global budget journey. And in Maryland, it's my understanding, a huge focus was on hospital savings. So we had hospital savings, but again, if we're going to a total cost of care is more important. The one thing I didn't produce was hospital savings, even though my total cost of care is still well within the frameworks. So all of that to tie into the point of what are you trying to achieve, and how will you know when you get there, as it relates to the various things you're trying to achieve. So as it relates to methodology, again, having run a program like this and served on the front line, I do want to reiterate what Bruce has stated. Methodology as developed needs to incentivize the desired behaviors. And so what behaviors do we want to see? What do we want changed? And our program has to make sure, as developed, needs to incentivize those behaviors. Our methodology didn't yield broad sweeping transformation for a couple of reasons. In rural hospitals, literally, we wanted them to redesign, move away from services that needed volume, things like orthopedic and some of these other things. But the reality is, because the financial position of our hospitals was so vulnerable, that because there was a global budget adjustment, so if they gave up a service to the extent that service went elsewhere, their global budget went down. And so we found hospitals hesitant to change service lines because they literally couldn't afford to get any less in their global budget because they were still operating in negative margins. And we also did this in the midst of the COVID pandemic, which I know you folks were running your ACO in the midst of that as well. However, despite that, I will say our hospitals fully engaged in the transformation journey. They could see the value of no longer having, let me focus on keeping people out of my emergency room. So it was enough, the incentives were enough that they did fully embrace the journey of population health and wellness. The one thing our methodology did not necessarily support, and again, some of this was taken from Maryland, is when you have a global budget adjustment down for a service line and the hospital's already losing money, and still losing money. So again, an important point is, while our hospitals improved operating margins through our program, that does not mean they were posting positive operating margins. So even within the global budget framework, because of the cost, ours is a revenue only model. And so, I think there's got to have some appreciation for cost as part of this if we truly want to get hospitals to sustainability. So again, what are we looking to incentivize? our hospitals did see enough of an incentive to fully embrace the value-based journey and took that transformation plan very, very seriously. Maybe not at a level we had hoped, again, because of the global budget adjustments. And again, one of the positive things that I think in AHEAD, we can clearly see the experience of our program in the AHEAD framework. As I read through the AHEAD methodology, can see our lessons learned. And so, again, we didn't provide any additional funding for social determinants of health and care management. So seeing that in the AHEAD framework to actually give upfront investment, I think is a very good change. We didn't have it. And therefore, our hospitals had to use money within the global budget to fund these things. And it really did stall some of the innovation. So while the hospitals were very willing, identifying the resources needed to do it is often where our hospitals struggled. So going back to a comment that Carrie made, our methodology is complicated. And I am all for simpler approaches if they can be achieved, because even at our stage, coming into the final years of the program, our hospitals and payers are still struggling to actually identify and understand the calculations. There's a lot of black box magic that happens. And, at least in fee for service, it's a fairly, simple. You provide the service, you build the service. There's a lot of complication that has come in because we know that's not sustainable. So suddenly you have all of these extra payments and everything coming in, but at least at the highest level, you provide the service, you get paid. And so, simpler is better. But I will say we created we started out to do something simple. We created a very complicated, I would say, machine. Part of that, quite transparently, was needed in order to recruit hospitals. In order for me to get hospitals to sign up, there were certain things we had to work into our methodology specific around market shift calculations. I'm pleased to see some of the language within the AHEAD. While we don't necessarily know the how, we can see that, we don't want to be doing these adjustments unnecessarily. So what are thresholds? What makes sense when we do some of these calculations? But again, I now have data to say, because I also will say our methodology did not necessarily create the most predictable revenue because of some of the adjustments that we were doing, as it relates to market shift and, retrospective reconciliations with prospective adjustments. So anyways, a lot of detail I could go in there. I won't bore you with it, but again, simpler is always better. Of course, there will always be some level of complications, but 6 years in with the global budget, our hospitals and payers are still scratching their head a little bit. And why that's a concern to me is that it undermines trust. And it also provides the opportunity to say, well, it's a third party vendor, and I would say, if I don't understand it, it's their fault. And it just creates, it can create a contentious environment. So I've got 4 bullets, elements for success that I offer all of you. Aligned objectives, i.e. goals, for all stakeholders that can collectively identify what the work is we are trying to achieve together. Can everybody speak to them? Does everybody actually know? Does everybody agree to the goals? And again, defining how we know when we're going to arrive. So for example, what does affordability mean? How will you know when it's achieved? Also, how will the global budget infrastructure help you achieve this? Do you see the pathway? My advice would be design the program based on the objectives, not the other way around. Ensure there's a value statement, a value proposition for every stakeholder at the table. So whether that's the payers, whether that's the hospitals, whether that's you, the Green Mountain Care Board, whether you're VHS or AHS there in Vermont, what's the value proposition of this work? Because the only way it's going to be sustainable long-term outside of mandate, quite frankly, outside of other regulatory metrics or measures, the only way it's going to be successful is if people can see the value proposition, the what's in it for me, the with them, as a stakeholder. And again, if you're going voluntary, that's work that needs to be done. If you're using mandates, maybe some of this becomes less important, but it's still very important that everybody can see the value of why you're doing this collectively. And then ensuring trust amongst the partners. So again, they would be my final My final thoughts to you as you're on this journey is can you describe what you're trying to achieve, and can you define how AHEAD is going to help you get there, or another, whatever the path is, what's the path to help you get there? I'll turn that back to you.
Great. Thank you, Janice. Really appreciate your comments. I'll turn it now over to William Henderson, and we'll wrap up with Robert Murray. Thank you.
Thank you. I'm William Henderson. I am Deputy Director of Medical Economics for the Health Services Cost Review Commission here in Maryland, and am responsible, among other things, for our discussions and point person with CMS, and do a lot of analytics to support the rest of our team here, and also responsible for value-based programs. So touch most of the aspects of the model here in Maryland. By background, I'm actually an accountant. I started as an auditor, working mainly in the healthcare space. Did some consulting work. I then spent about 15 years in the payer space at a national managed care plan. And then I came back to Maryland to work at the HSCRC, was recruited back here by folks I knew from my accounting days. And I think one of the reasons, the big reason I came back was it felt like, having spent 15 years in the national payer space, and although I was based in Maryland, our business was almost entirely outside Maryland. You know, I really felt like we had a system that didn't work, right? That ultimately we've got a lot of decisions being made about care in terms of cost and quality and efficiency that are made a long way away from the patient. And I think generally the best decisions are made closest to the patient by somebody with a full set of information. And that a lot of the strategies that payers use are, you know, well-meaning, hopefully, but are also ultimately removed from the patient, right? That the insurer is a long way away from the patient. And so I came back to Maryland because one of the things I thought was interesting is the model here, and the global budget really tries to move decision-making closer to the patient, in that it gives the hospitals a stake in some of those decisions that they don't have right now. Now, the hospital is also not the doctor, but they are, I think, a little bit closer to the insurance company, and that if we can align their incentives into the right kind of decision-making, that had promise. And I was really excited about a chance to work in a model that that had some promise. And now I'm, you know, 5 years of maturity from that. I have some of the same thoughts, and I think the promise is definitely there, but I think we are all still trying to figure out how to fully capture that promise, and you know, agree with many of Janice's comments on that. So I'm going to go through, you know, I think 3 areas that are fairly critical, I think, to us in terms of how you design global budgets and how they operate. I think the first one, and I've already hinted about that, is in my mind, the global budget should be founded with a somewhat different vision for the role of the hospital in the community. And that, right, historically, the hospitals have been focused on delivering care to sick people. And one of the great things about the global budget is it changes their incentive, where suddenly every time somebody walks through the door, you could say the hospital has failed from a financial point of view, right? And so suddenly the hospital has an interest in a healthy community, a community that can seek care in the primary care office or in an urgent care and not have to come to the ED. You know, a community that has adequate access to things like ambulatory surgery centers and infusion centers, which are convenient for the patient and work in a vast majority of the situations, rather than pulling as many patients as they can into sort of the hospital infrastructure. And so I think there's a lot of promise in that. And I think hospitals are generally well positioned in that, particularly in rural communities, right? The hospital is often the largest employer in town, or the second largest employer in town. They're connected to the leadership within the community. They're a big player. They have big pockets compared to everybody else, certainly. And therefore, if you look at how a hospital operates, again, particularly in a rural or smaller community, right, they're in one of the strongest positions to really promote community on community health on a broad basis. And I will say some of our hospitals have done an excellent job with this in terms of thinking about their role as promoting health in the community. And the global budget really is just what makes that possible, because suddenly they can focus on how do I keep the community healthy and not how do I maximize the number of surgeries I'm doing in my OR. I think there's challenges in that revised role for hospitals. One, right, culturally, that is not what hospitals have done historically. Historically, they have been focused on treating patients. They will tell you they are not public health experts. They've got physicians who potentially aren't on a global budget, who are still reimbursed on a fee-for-service basis and therefore not aligned with that motive that the global budget brings. I think ultimately some of them will a little hesitant to take that role, right? It requires a change in mindset, and frankly, hospital leadership has been brought up to lead hospitals, and I think the things we have valued in hospital leadership include things like building really nice big new buildings and recruiting the maximum possible physician staff and things that I think all have value, but which take a very different spin if you're going to ask the hospital to take the role under a global budget of a community health leader. So I think that's my first area that I don't think we have really solved either, is how do you understand what you're expecting your hospitals to do under a global budget model, and whether they're capable and willing and able to do that. And I think we've had mixed experience. I think the second thing is the role of global budgets in managing volume. And I think on paper, there's a really nice relationship here, right? Because when you think about the more rural hospitals whose challenges is dropping volume, the global budget protects them from that. And that's the goal of that, to keep some stable funding and hopefully allow them to continue to provide a baseline of services. Because some of the challenge with hospital services, right, is it's not all volume driven, right? No matter how much volume you have, if you're the only provider for many miles, you need to have a 24-hour ED. So giving them that protection is, I think, important on the volume downside. And then the theory would be on the other direction, it provides a different incentive because the hospital doesn't gain by just finding more and more volume. So hopefully they think a little bit differently about how they're relating to their physicians and how they're relating to their patients in terms of readmissions, right? Which I think everybody's aware of is really the sort of slam dunk of global budget policy, because suddenly a hospital has total incentive to minimize their readmissions, because really there's absolutely no benefit to them to delivering care that results in an avoidable readmission. So I think that's the nice thing about global budgets and volume, is that it really, I think, manages our risks on both sides. I think the challenges in that really comes down to access and how do you measure access. And a lot of the pressure we have seen is hospitals saying, look, and this is more in the urban areas, look, we're all focused on managing this volume down, and it's sort of a competition, and who's making sure that the patient can actually get the services they need, right? Because there are clearly services people need. We don't want anybody to have to go to the ED, but people do need to go to the ED some of the time. And so I think an area that we're really looking at is focusing under a head, and it's surfaced in places, is how do we measure access and how do we incorporate access measures into monitoring our global budgets? I think the same can be said on the rural side. It's a little bit of a different challenges, but having access measures so that you understand, where are we pushing too far? If we are encouraging people to decrease volume all the time, how do we make sure we haven't gone too far? How do we make sure people can still get to a hospital or a physician when they need to? So I think we've really seen it works great in volume, but you need those guardrails, and I think we see the guardrails ultimately being as effective access measures. I think the third theme, and Janice actually hit this one quite a lot, is this whole tension between complexity and simplicity. And GBR, global budgets, they do introduce new complexity. And I find that people make the mistake of thinking that the opposite of complexity is simplicity, but in most of these things, the opposite of complexity is unfairness, right? That is almost invariably why our policies end up getting complex, is because we start with a simple policy and somebody says, but wait, that doesn't work for the hospital in XYZ situation. And so then we add a clause that says, in that situation, we'll do something else. And then somebody else points out that, well, that doesn't work in a situation. The pandemic, right, created a whole ton of new situations. So I think, you know, I don't think there is a simple answer that is also fair and sustainable. So you have to accept a certain level of complexity, and that requires a certain level of investment. You know, I think the good news is it's probably easier for a smaller state than it would be for a larger state. You know, if you're talking about California, I would guess the amount of different circumstances they have is exponentially larger than we might have in Maryland or you might have in Vermont. So I think that complexity is perhaps a little bit more manageable, but I think it is important to communicate to people that, look, if you know, if there was a simple, easy answer to managing healthcare, we would have already done it, right? Any system is going to have some level of complexity. And I think, you know, fee for service has a ton of complexity. To echo a point Janice made, we've kind of got used to it, and that's how hospitals are used to managing, and physicians and so on. But there's a ton of complexity in a fee for service model. It's just hidden in different corners. And I try and remember when people are concerned about, well, the global budgets do this or the global budgets do that. Well, let's remember the counterfactual here is not the perfect healthcare system, right? The counterfactual is a system that we have in 50 states and have had for years, and has generated, you know, cost growth that I think most observers would say is unsustainable, and at the same time, you know, fails to provide high quality care to a fair proportion of the population. So I would encourage people, as you talk to them, you know, to be careful. There are certainly gaps in global budgets, and there's certainly blind spots. But again, we're not comparing this to a perfect system, and we need to evaluate the different systems and understand which one has the best combination of merits for us, and not act like any new system must jump over some impossibly high hurdle to be worth it. So I think I'll wrap there, and I'll turn it back to Alita.
Thank you so much. And our last but not least, Robert Murray.
Hi, thanks very much. I'd like to share my screen. Hopefully this will work. And it's not allowing me to pull up the tabs. Let me see. Maybe this will work. Can you see this? No. I'm sorry, I always have trouble with Teams.
There should be a little box next to the leave button. Always gets me in trouble. They're too close together.
Yeah, I see it,
Oh, you
but
see that. Okay.
now it's asking me to share. Maybe if I do my window. Oh, here we go. Okay. Can you see that now? Nope.
Not quite. I give you a quick window, and then if you've selected the.
Yeah, I do. I'm on window, and then I'm selecting my PowerPoint, and Teams won't allow me to call it up.
If you'd like to send me your slides, I can pull it up.
Okay. Yeah, I'm sorry. I just had problems with Teams. Let me send you. Unfortunately, it's animated, so you're gonna have to. So let me just send it to you. I should have done that to begin with. Okay, I apologize. And then I can get started, and then you can call it up as we're getting through this.
You want to start with an intro while I wait for?
Yeah, I apologize.
Okay.
I can't chew gum and walk at the same time. So
I understand. Thank you.
yeah, all right. So I sent it to you. Anyway, well, intro. I'll be very brief here. As you'd mentioned before, I was the third executive director of the Maryland Health Services Cost Review Commission. And then Elena, when you got the deck, let me know. You can pull it up. You'll have to go through it, though. It is animated. So since leaving, when I was at the commission, we had some problems with volume growth in the 2000s period because we'd gotten rid of our key volume constraint methodology in the 90s. And we tightened down on rates in the late 90s, early 2000s, because we were in danger of losing our waiver. And the combination of getting rid of the volume adjustment, which really constrained hospitals' ability to increase volumes under the fee-for-service structure, and tightening on rates resulted in hospitals just exploding their volumes across the board. Cases, tests, ancillary services, outpatient services. I mean, it was really remarkable. We wrote an article about it. But and so in response to that, we tried to put in, bring back the volume adjustment mechanism, but also implement global budgets for the rural hospitals. So we started that in 2009. Basic idea there was to try to do a regional type of system, put the hospitals that are more in the rural areas under global budgets, and then manage global budgets more regionally using the authority of the HSCRC. So that's really, I guess, the primary area of expertise that I have is in setting up those types of models. Back in 2014, 2015, I also was consulting for the Green Mountain Care Board and proposed a model very much like the model that I'm talking about based on flexible global budgets. But the state instead decided to go the way of using ACOs to try to create a population-based payment model. So Elena, have you?
I still don't have it in my inbox.
Sorry, we should have tested this out. Let me just make sure it was sent. Yeah, I did send it. So let me see again if I can possibly pull up the
I
screen.
got it. So I
Okay.
just have to pull it up.
Again, I apologize for this.
No worries.
I think Microsoft should be eliminated as a high-tech company. But anyway, that's my bias. So just pull it up whenever you can, and then I'll just ask you to go through it, you know, click by click, if you could. Maybe do presentation mode. Great. Okay, just advance through it. And so initially, I just want to provide my biases with regard to payment reform. I think it's still the prices that are problematic. Maybe go to the next point. So the focus needs to be on price and constraining price and spending growth. And in doing so, setting constraints, you address the key market failure, which is non-competitive hospital markets or provider markets generally, but particularly hospital markets. And by setting a constraint on price, you have the ability to provide incentives for hospitals to control their costs, to manage their costs. The experience that I had in Maryland is hospitals, when they face a constraint, they do manage their costs and they improve their operational efficiency. And under global budgets, they have the additional ability to remove waste and unnecessary services to generate savings moving forward. So my thesis is that the big problems in healthcare caused by market failure, non-competitive hospital markets, and also moral hazard, and also the tax preference for insurance premiums, those two factors desensitize insurers and patients to the cost implications of price growth. So you have this perfect storm nationally of consolidated hospital markets, which are non-competitive, tremendous pricing power in combination to an insurance system that desensitizes the cost implications of price growth, which just feeds right into the pricing power of hospitals, highly consolidated hospitals. Just if you go to the next couple of slides. Market failure, if you think of classical economics, market failures require government intervention. And in Maryland, the HSCRC, the legislature realized that they needed an agency like the HSCRC to address these market failures. But the quid pro quo was that only intervene to address market failures and try to avoid unnecessary interventions, which is very difficult for rate setting agencies because they always want to overregulate. My other bias is that voluntary payment systems don't work. You can look back historically, you can look at voluntary arrangements at state level, the federal level, at the Carter Initiative that turned into a voluntary initiative. They don't work. It's like having a voluntary tax system. These sorts of things just are not effective. The next point, population-based payment is a great ultimate goal, but it's something that's highly complex. It can only be implemented by systems, closed corporate systems like a Kaiser, or a system like the Israeli system, which is enforced by rate regulation and other regulatory guidelines. But you need extreme integration, clinical integration through ownership of the insurance function, the provider function. ACOs are not going to get you there. The next point. I think states have the best opportunity to set up what I think is required, which is mandatory rate setting systems to address the key healthcare issues, is it primarily price and spending growth. The next point. The key to change, as has been discussed before, is changing the incentives, but also to ease the transition by initially preserving some of the key administrative and operational features of the existing system. And so the model that we developed for Vermont tried to do both. The next point. Well, I think that Vermont is uniquely positioned to really have a very, very effective health reform and spending approach because of its the regional nature of the state. If you could go to the next slide and just click through this slide. You know, I'm not telling you anything you don't know. This is a slide that we prepared for some of our presentations before. But just, Elena, just go click through some of these things. So I think the great thing about Vermont is you've got these regional healthcare systems where the populations are naturally mapped to hospitals. Many of them, most of them are rural, but it's a very positive basis for creating an overall global budget system. Just keep clicking through if you could. So again, I thought that Vermont was very uniquely positioned. The Rochester and Finger Lakes model was very much of a regional model. I had a lot of characteristics that I think that are very positive and opportune. It was a simple model. It was formula-based, and it was very effective for the period 1980 to 1987. And it was implemented under the auspices of the Healthcare Financing Administration, which is the administration that ran Medicare, different name, but they have experience with these types of demonstrations. Go to the next slide. So some of the characteristics of an effective system operated by a small independent agency. This is true of the Rochester Finger Lakes system. Agency had broad powers to set and update provider rates and other goals, primarily focusing in on this idea of constraining price growth and spending growth and setting constraints for hospitals to improve their operating efficiency and reduce waste. Agency would have strong enforcement authority, and there would be an emphasis on, if you could just click through these, establishing very clear, attainable financial targets for hospitals, focused on formula-based rate methods that are relatively simple and well understood, preserving existing payment infrastructure. I'm saying the model that we developed for Vermont previously retain the existing claims processing system of Medicare, Medicaid, and the commercial payers, so they didn't need to change that. I think there's some disadvantages to the HEAD model, which is it completely tries to change the way hospitals are paid, which is not a bad idea, but it's difficult to do, and it creates additional unnecessary complexity. But the locus of control is at the hospital global budget level. Our preference is for flexible global budgets, not fixed global budgets, which we implemented with the rural hospitals in 2008 or 2009, 2010, and exists there currently. There are a myriad of other adjustments, but I think those adjustments are largely unnecessary if you do a flexible approach as opposed to a fixed approach. Next point. There are flexibilities in terms of how you structure a flexibility approach. But one of the key elements of this system is mandatory participation by all hospitals and all payers. If you don't have all payers participating, they're not contributing appropriately or equitably to the funding of the global budget. And if you have some hospitals in, some hospitals out, you're truncating the incentives. You need uniform incentives. The best way to do that is through an all-payer system where everybody participates. I think there may be one more point on this slide. Yeah, cooperation with payers too in designing incentive-based payments for physicians to try to weave them in. There's also the potential to bring in hospital-based physicians under the global budget. Go to the next slide. So just click through this very quickly. This is an example of a medium-sized rural hospital in Maryland, 100,000 population. The budget was set at $250 million because that was the historical budget. And then the model itself, as I said, was relatively simple. The budget is adjusted by two things. Estimated cost inflation, which we use the Medicare market basket to do. So if you just, Elena, just click through this. So the adjustment for inflation, just an example, 2.5%, an adjustment for demographic changes. So you get the new budget at $260 million, and then all the focus for the hospitals to control costs, that $255 million. And by improving efficiency and also reducing unnecessary service use and waste, you can control costs and then keep clicking. You can generate a profit, and so that you have a situation, just click through this, please, where unnecessary utilization and unnecessary inefficiency are sources of financial sustainability for the hospital. If they focus on removing or reducing those, they can generate surpluses and profits, and then hopefully reinvest those profits into population health and other remedies to reduce unnecessary use and support population health in their regional communities. If you could click through, I think I have a couple. So unlike Maryland, we propose a flexible global budget approach, which it pays on the basis of variable costs, but preserves funding for hospital fixed costs if volumes decline. And I can go into more detail about that. But Elena, if you could go to the next slide. So this is, just click through this as well. You have extremes, fee-for-service model. You have on the other end of the spectrum, fixed global budgets. We know the obvious problems with fee-for-service encourages unnecessary volume growth because marginal revenue for each service a hospital provides is in excess of the marginal cost. Fixed global budgets goes to the other extreme. I believe that fixed global budgets, even though we recommended them initially for the rural hospitals in Maryland, they provide too much financial risk for small rural hospitals. They also incentivize stinting on care. And so as a result, you get reductions in elective services that are provided by hospitals and also high ED wait times, both of which I believe characterize Maryland currently. By contrast, in the middle, flexible global budgets, as I said, pays on the basis of hospital variable costs. It means that you don't need to have a complex mechanism to address market shifts. And the idea of keeping this thing as simple as possible, but it provides predictable revenue for hospitals, in particular small rural hospitals, because A, it doesn't provide excessive level of financial risk. Under fixed budget, you get something that's unexpected in terms of utilization, morbidity, or mortality changes, and it can blow the hospital's budget out of the water and create huge financial solvency problems. Under a flexible global budget, they're paid on the basis of volumes and their variable costs, but they also have a funding that's guaranteed to cover their fixed costs should volumes decline. If you could keep clicking. So again, it's a middle ground approach. I think it's something that's softer, gentler, and it's more suitable for a state like Vermont that has a mixture of larger hospitals and rural facilities. Go to the next slide. So just generally, this is the concept, which is you've got the current trend, which is in blue. Setting global budgets gives the state the ability to set a hard ceiling cap in terms of revenue growth on a per capita basis. And then click in the next. You get a lower trajectory, you realize per capita savings over time, and you can, as a state, you could try to equate that with growth in gross state product to ensure that the health system, the hospital system is affordable moving forward. Go to the next slide. So key success factors, the regional orientation of the model, cooperation with regional actors like payers, the primary care physicians, FQHCs. I think that's another advantage of Vermont is that you have a very strong FQHC infrastructure in the state. Set clear financial incentives backed by strong enforcement. Again, mandatory systems work, voluntary systems don't. Try to set up very, very straightforward, well understood targets, attainable targets in formula-based rate setting. These are all characteristics of the Rochester and Finger Lakes model, but otherwise avoid as a regulatory agency to intervene in operational decision-making of hospitals, and also avoid the tendency to react, to have the squeaky wheel phenomenon, and as an agency react to hospitals that complain about things. That's the circumstance that's existed in other rate-setting states, where the regulators are overly responsive, they react to complaints by the industry, and then over time they layer on this change to that change, and the system becomes so complex, as it did in New York and New Jersey, and I would argue to a certain extent Maryland, that even the payers and the hospitals don't understand the incentives. So regulatory agency needs to resist the tendency to constantly change the system. It's a macro regulatory model, not a micro regulatory model, or focus on aggregate revenues or compliance. If you have strong legislation to control both rates and also aggregate budgets, you can achieve savings as intended. Again, formula-based. You need Medicare and Medicaid to participate. If you could continue clicking, Elena. The two dangers to rate setting, regulatory failure and regulatory capture. I've written about both of these. But this approach is structured to avoid regulatory failure, which is the excess complexity that is a tendency of rate regulators. Going back historically, I think there's one other bullet. You can have structural protections to the rate agency to avoid regulatory capture. We advocate a public utility model of rate setting. Go to the next slide. So again, I think Vermont has the key ingredients. You've got a small agency. You can adopt a public utility approach where all deliberations are in public and transparent interactions and a methodology development and debate. Act 48 back in 2011 gave the Green Mountain Care Board rate setting authority. So thus you already have that. It could be modified or perhaps enhanced if necessary. Mandatory rate setting also can be designed to avoid ERISA preemptions. That's not the case if you try to structure payment the way the HEAD model has recommended, like per capita amounts for all payers, including commercial payers. Those will be challenged by ERISA plans. But if you set up a system that's structured the way we had recommended, it will avoid an ERISA challenge. And you can collect data directly from hospitals, so you don't have to go and get the data and be preempted by ERISA, get the data that you need, because you largely need hospital level data. And keep going, Elena. The regional orientation is a huge advantage for the state. And so the state should study the Rochester Finger Lakes demonstration. I think it has the characteristics that I mentioned. It's relatively simple. It was formula-based. It set targets and standards, and it didn't futz with the rate-setting methodologies excessively over time. So the system stayed pretty straightforward, and the incentives were very clear for the hospitals, and it was hugely successful. There was involvement by the State Department of Health in New York. Keep going, Elena. They're regional models focusing on regional healthcare needs. And then, so that just have you a little display of the transition slide. So anyway, that's the final slide I had, and I'll be happy to answer questions. Sorry for the logistical problems. Maybe next time we can use Zoom. Anyway, thank you.
Thank you. I appreciate everyone's comments. So I'll open it up now for board questions, and Chair Foster, I'll let you manage your people.
No, you nailed it. That's all you got to do. Good job. Go. I'll go last. So any board members, please, for the floor, ask anything you want. All right, I guess I'll go first. I got a whole bunch. I don't know who they're for, but I'll just kind of go through them. The first one I had was, I think a couple of you made the point about the amount of money or providers or insurers that are in global budgets. Currently, we have 2 hospitals that have, well, maybe more than 2 because UVM was more than one hospital, but a couple hospitals that have expressed interest. And so far, it's not clear if insurance will be in or not. Do you have a sense of how much money needs to be in the global budget to drive the changes in incentives that we're seeking?
I'm happy to take a stab at that one. If, at least from my experience, I can say, Owen, when we got to about the 60% revenue from a hospital's global budget, it was about, because we're an all-payer program. We've got the prominent payers in the state at the table. There were, COVID interrupted that. So the hospitals that joined at the end, we needed to recruit a couple. Our goal was 75. When we could get to 60, we could see the hospitals seeing it was worth their time to change the delivery system. So from my experience, it's roughly 60% of the hospital only. So again, not physician revenue, but 60% seemed to be the tipping point for our hospitals.
If I could just jump in really, I think it needs to be much higher than that. I mean, anytime you have truncated structures, you're going to have different incentives for different players, and that's going to be highly problematic. In Rochester, they had over 90% of the revenue under the global budget, and it worked very well. In Maryland, it's 100% by law and regulation. So I think in the 90 to 100% level is ideal. And if you back much away from that, and you have some participating and some not participating, hospitals or payers, you're going to get conflicting incentives, and that's going to be highly problematic in terms of responding to the key incentives established and achieving your goals.
So just to echo, I would say 90% was our ultimate target. We didn't get there. 60% is when hospitals voluntarily chose to come to the table. So again, the more the better. So just to, highlight what Bob said there, obviously higher's better, but for the hospitals that chose to participate, that was the tipping point.
And if you're low, 25, 30, 40%, are there risks of focusing care on care that's outside the global budget? Is there a downside risk if you're too low?
Yeah, well, I think you just have, again, the conflicting incentives for the hospitals that are under global budgets are decided, they'll try to ship patients out. They may try to manage, but they have the incentive to shift patients to the hospitals that are under global budgets or freestanding centers. So you just get these conflicting incentives, and it's highly problematic, and you get tremendous leakage in the system. So again, the systems that have worked the best in the past are mandatory, are enforced by strong rate regulatory authority and regulation, and are all inclusive, have the majority of the participants there, so they're all operating under common incentives. And then it provides a locus of control at the regulatory agency to achieve their goals. And again, primarily goal would be control price growth and spending growth.
Okay, 2 related questions. Right now, Dr. Hamre and his team are working hand in hand with the state on hospital transformation plans to make sure we have the right footprint and available care where we need it, transportation, all these various components. And then we're also simultaneously looking at and evaluating global budgets. And to me, it seems like there could be interaction between those 2 things, maybe even beneficial to do a global budget first or to do the transformation first, or simultaneously do both. I was kind of wondering what the expert panel thought about that process. And the recommendations from Dr. Hamre are going to include a whole swath of things, such as potentially focusing care in particular areas, or improving transportation, or whatever it might be. So I was wondering what you guys thought on that.
Bob, do you want to start? Go ahead.
Yeah, I'm sorry, I don't want to dominate, but yeah, I think you can do them simultaneously. And I think they're both very important, very crucial. As one of the great things about the Pennsylvania model is these transformation plans. Because one thing you can do with a mandatory rate setting system is the agency can build in additional amounts to help finance care management initiatives at the hospital level. So you can actually fund then jumpstart a model like this. But it's very important to have a plan and to have strings attached to the additional funding that you provide to hospitals. Otherwise, they'll spend it the way they've traditionally spent it, which may not be focused on the goals of the new model. So those care transformation plans are very important and need to be linked back to additional financing that are provided initially to jumpstart a population-based model like this for hospitals.
I'll add that I was thinking that might be what you would do with some of the initial payments, like the grant type payments in the AHEAD model, was to work on some of those infrastructure issues. So I think there would be interaction effects from having both simultaneously.
Yeah, and I would agree with that because it was the global budget that allowed our hospitals to actually start focusing on the transformation, the care management, social determinants of health, trying to keep people out of the hospital. Again, my lens is rural and, they really couldn't afford to do that before, but the global budget allowed them, to build utilization registries to identify, those that had a lot of ED utilization and really, again, pragmatic approaches to understand why are they coming into the emergency room? What's the condition? And it truly was the transformation plan. So to quote one of my CEOs, again, we attracted in a voluntary program, I would say the forward-thinking leaders. But one of the things that he said was for the first time he felt he was brought to the table as a partner on the population health journey versus a cost center. But really, the global budget and the required transformation brought him to the table as a partner in the journey versus, again, the viewed cost center that historically the hospital has been viewed as. So,
Bruce?
Yeah, well, I guess, no, I think it's a good discussion and very worthwhile. I guess maybe a couple of points would be helpful. One, there's only one county in Vermont that has a population of 100,000 folks. Most of them are really 25,000. As you've noted, largely rural, lots of social determinants of health issues to be addressed. Many of the hospitals are spending part of their budgets on some of these issues. Now, in fairness, I visited every hospital in Vermont within the last 3 months. And some of the folks are saying, I'm now looking at cutting those because I can't make my margin. So, I think that may be an advantage to global budgets. I guess question, though, is many of the smaller hospitals are running an inpatient census of 10, with 2 of them who don't need to be there because they're waiting for a mental health bed or something. The only hospital, I've heard from a couple of the bigger ones that they may have a variable cost that's 5%, which in their budgets would represent a lot of money. Now, I see it, but that's what they're telling me. The other thing I'm wondering about, particularly with the small rural ones, is how much of that budget is really flexible, right? Because if they're having to keep an ED visit room open, in a sense, volume's immaterial if they're staffing it. And to some degree, the nurse-patient ratios on the inpatient side affect that. So I'd be very interested in how those issues have been addressed, are being addressed, could be addressed with a global budget. And I think you commented on how those budgets are set, which makes a great deal of sense, because I know one of the concerns of the hospitals is that as those budgets are rebased based on their inpatient, their budget, their dollars, that they will go down over time. I guess the other question related to that is I ran one of the original PGP demo projects back in about 2006, and we had persistent problems with the Medicare adjustments of expected cost. And so how that might be addressed.
Well, I don't know. I mean, with regard to variable costs in the flexible budget, you can adjust the fixed variable cost relationship. We recommended for the small rural hospitals to structure it such that payments were on the basis of hospitals fixed and variable costs being more like 80% fixed, 90% fixed for the small rural hospitals, 20% variable. So you can adjust things. You wouldn't titrate it, individually for each hospital. But for the rural hospitals, they have higher proportions of fixed costs. So the flexible budget should reflect that. And as volumes decline, then it would provide that support to cover their fixed costs if volumes decline. For the larger hospitals, and this is the case in Maryland, the variable costs were more like 50–60%. That was based on studies that we've done over time. And that structure from 1976 to 92, where the hospitals are paid on the basis of their incremental variable costs for volume increases, was very, very successful because that 50–60% variable cost more or less equaled the marginal revenue that they get for incremental volumes. But it wasn't as excessive as a fee-for-service system, which pays 100 cents on the dollar for marginal volumes. So it neutralizes the incentive to unnecessarily increase volumes, but then provides that funding for fixed costs if volumes decline. So that in a nutshell is the genius of the volume adjustment system or a flexible global budget. And you can tailor it to a certain extent, but resist the tendency that regulators have, which would be to micro structure the system, which tends to make things, as William has said, makes things, yes, potentially fairer, although that's a subjective judgment, but it also tends to make rate setting systems far too complex, and then these systems collapse under their complexity over time. And also, just one last point, the 100,000 people that I mentioned, that was just illustrative of Maryland. You could structure that for counties that are 10–20,000 people, or the Burlington area, and structure it for different size regions and different size hospitals.
Yeah, and I would just echo that. I think that's one of the concerns we have in the current program, as well as the ahead, is there's not necessarily the recognition of cost as you're looking at just protecting the historical revenue and basing a budget on historical revenue. There's not necessarily a correlation between historical revenue, and cost. And so making sure that there's some lever in the global budget to account for costs, and especially, and we were experiencing a large inflationary, inflation like we really haven't experienced for decades. And, the methodology has to have some metric in there versus just a historical revenue. Doesn't necessarily give you that flexibility to ensure cost structures are appropriately considered.
So on that's very pertinent, I think, to what we have in Vermont. So if you look at the global budgets with the Medicare market basket, you're going to be looking at 2, 3, 3.5% rate increases, right? And I can tell you our hospitals have not been able to survive on that, not even close. So in the last 2-year period, the system-wide commercial rate increase request was over 20%, 21%, right? And then if you look at our relative pricing, our RAND pricing, we have hospitals that are, I'm going to go through them. CVMC, the 7th decile, UVM, the 9th, Rutland, the 8th, Brattleboro, the 8th, Southwest, the 8th, North Country, the 7th. So very, very high relative prices, right? Very, very high rate increases, very, very high commercial rate grants by the board. Despite that, we have, I think, 8 or 9 hospitals with negative operating margins. So my fear is on a global budget where Medicare is 2% or 3%, what we see, at least in Vermont, is that's not going to hack it in terms of enough financial support.
I think it goes back to something that one of my colleagues said earlier. I'm not sure which one, but it really comes down to redefining the role of the hospital. So I think part of this is presuming we're going to keep offering the same services, the same thing that we've always done, but that's not necessarily sustainable. And so having to redefine, if we're asking our hospitals to step into a new space and do things differently, I also would recommend and challenge you, make sure that you're paying for the right care in the right community. So I think, and again, I'm offering you firsthand things that I'm hearing from my payer community. So we've got all of this. So while our current program only has, some participants, where we're trying to go as a state is to get all of our payers at the table. At this point, voluntarily, not mandatory, but they're all raising their hands saying we want to be on this journey. But that's the question they're asking. Are we sure the global budget is actually paying for the care we think our rural communities need? And so it really, to me, goes back to, looking at some what Bruce put up there and some of the other things. It's like, what is the care that we want in our rural communities? Because today's fee-for-service environment, let's just call the spade, does not necessarily pay for the care that we need, as I think it was Harry that said primary care, urgent, emergent, mental health. That's not what keeps hospitals open today. What keeps hospitals open today, and oftentimes they're chasing, and again, a former hospital leader here, you have to balance and currently chase services that allow you to post the margin. So part of this work has to be, what are we actually asking our rural hospitals to do? If we want primary care, urgent, emergent, and some semblance of inpatient. I also lead the National Rural Emergency Hospital Technical Assistance Center. So I work with hospitals across the country that are considering that designation. And policy as it stands today, I personally don't think is what it's in the best interest of our rural communities. I think some inpatient care should be allowed in these communities for a host of reasons. But if we want, a semblance of swing bed care, rehab care, all of this, that's what I'm saying. Design what you want to pay for, like figure out what you want to pay for, and then design the program to do that. Because our payers, again, going back to Pennsylvania, saying we build a budget based on historical revenue, which includes some of these things that are not necessarily, pain management clinics, orthopedics, some of the things that have historically had to be provided in order to keep the hospital open. But if we're going to fundamentally change the paradigm, we have to describe and define what we want paid for in rural communities. And so it's a big, like, what do we want to pay for? And does our new model actually incentivize the hospitals to move into this new space, start population health, all of that, but then we still need them to be there because people still need emergency rooms. A readmission rate of 0 is not necessarily good. There are people that need to come back to the hospitals. So it's like we need emergent, urgent, but there's other things that we could be doing within that fixed cost structure to actually move the dial on population health. So I'll get off my soapbox. Sorry. Others?
Bob and Bruce?
Yeah, just a couple of quick points. One, hospitals are always going to tell you they need money, more money. And that's not true. You need to realize it's a balance. It's a quid pro quo. It's not just about hospital payment. It's also the quid pro quo is hospitals need to be under constraint so they have the incentives to manage their costs more effectively. And the beauty of a rate setting agency is you can do that gradually. You can ease them into that new structure and make these incentives very, very, very clear and reward them for achieving those targets and goals. Start and then to Janice's point, to start with historical budgets the way they are. They've operated under them. Start with those as the basis of your hospital budgets to begin with. And then the idea is gradual change. And if you have a rate setting system, you have the ability to differentiate updates. You can have slower rate updates for hospitals that are very high priced, some of the ones that you mentioned that have very high proportions of Medicare for what they're getting currently from their private insurers. But you can also raise the rate of growth for hospitals that are struggling gradually over time. So you have that control if you have a mandatory system with rate regulatory authority to adjust rates, set rates initially and set global budgets and then adjust them over time. But the idea is to impose constraints gradually, so hospitals have the ability to change their systems and adapt and manage the care appropriately over time.
Bruce,
William,
you're,
go ahead.
Bruce, you're muted, and then William.
Sorry, I think that's all right. I guess the question I have is how you align the incentives between, let's say, the various state agencies which are providing the mental health and the family support and so forth, and those FQHCs which run on a different payment system. Because you're right, I mean, the vast majority of primary care in Vermont is being provided by the FQHC. So, but they have a different funding stream. So how do you get those aligned with where you want the hospitals to go?
We just very briefly, we did look at that. We talked to folks like in Rutland. They have a very close relationship with the FQHC there. That was also true about Springfield, I think. And so there are ways of extending the hospital global budget incentives to FQHCs. It's too technical to go in here, but we discussed the very, very important role that FQHCs could play. And then also some of these other points that I mentioned about trying to encourage a primary or the payers, the commercial payers to set up incentive structures for physicians, primary care physicians, and also specialists. And there are various, shared savings risk arrangements that could be structured there to create models that align the incentives of physicians with the global budget hospitals.
Great, thank you.
Sure.
I was just going to add to Janice's discussion of the system you want. I think one of the things that's nice about global budgets is it forces you to think a little bit differently about what you're paying for, because reality, right, when you pay 20% more for another unit of inpatient service in a rural community, you're not actually, it's not that unit of service is that inpatient stay is 20% more expensive, right? It's that potentially they're trying to sustain their underlying infrastructure, and it's potentially that they're experiencing an acuity mix. And so one of the things we're trying to move towards is understanding the cost of the infrastructure, right? If you want to have a 24/7 ED, that is going to cost you a certain amount of money. And trying to spread that over whatever number of units that the hospital happens to get isn't really a great way of thinking about it, because that is not a cost of each of those units. That is a cost of maintaining access in the community. And I think that links back to my point about understanding access. So what system do you want to have? What access do you want to guarantee? And then you're going to have a cost to that. And then you've got the cost of actually providing the service. And you almost want to separate those two things. And I think it would help normalize your cost growth into something that's more rational. I will say, by the way, I think CMS has underfunded inflation on IPPS and OPPS for the last 3 or 4 years. I think that's MedPAC keeps suggesting that they should add more onto that. So I think that's, a function of the way CMS is reimbursing inflation as much as it is what the real inflation is.
Great. Thank you. Well, I don't want to take up more of the time because I'm sure the other board members have great questions. So thanks for indulging mine, and I'll open it up to the others.
Maybe I'll just hop in with just.
Go ahead, Jess.
Oh, okay. I just was going to hop in because I think, William, you brought up this point earlier and you just repeated it again. And it's a bit about the access, and it's how important it is to monitor and measure access. And I think it also relates to a point that Carrie made about mitigating unintended consequences and strategic behavior. So I'm actually going to lump the two of those questions together and say, I think stinting of access is a potential unintended consequence. So I'm wondering how you monitor that, how you suggest monitoring and measuring that, one, and what other unintended consequences or strategic behavior should we be aware of and think about ways to mitigate if we go forward?
Well, I don't know that we have we are struggling with the access issue, our question ourselves now. So I don't know that I have a silver bullet there. I think you do need to have some consensus in political leadership and healthcare leadership and so on around what, we have hospitals in rural areas that if I took a pure analytical point of view, I would say they just shouldn't exist, right? But that's easy for me to say, sitting in Baltimore, where I am, what's the reasonable distance for people to travel? Quality issues, I think, as you all know, it's very hard. 10-bed hospital, it is hard to believe, very hard to sustain a high quality care system with that. So I think those are tough choices. I don't know that we have a silver bullet for that. I think on the unintended consequences, you have to, how I think Bob or Janice referenced market shift, right? That's the methodology we use to shift money when volumes move, right? Because Hospital A was providing this set of services, now Hospital B is providing it. You need to have something robust there to make sure that you're not rewarding a hospital for simply stopping providing services. So I think that's an aspect there. I think the access, we have a pretty robust hospital quality program, right? So we're trying to make sure that we're monitoring, things like avoidable complications and so on, so that you make sure you're not incenting, thin care delivery. Those are the things that occur to me off the top of my head.
It'd be
I'll
really
let
helpful if
others-
you're willing to share some of that, just in the sense that I know, and Dr. Hammery is working very closely with the board on just exactly these questions of looking at what's appropriate access, what are the essential services that need to be nearby, what could be moved to centers of excellence, how do we start to think about quality and low volumes and what should be delivered and can be delivered at a low cost, high quality level. So Dr. Hammery's work, working with all the hospitals and evaluating data is just about that. But I'm wondering, to the degree that you've learned from this about how you're monitoring quality and low volumes and those shifts. And also we're thinking about wait times and how do we measure access via wait times. And it's been a struggle to try and do that. How long are patients actually waiting for care? What's a reasonable amount? How do we gather that data? Right now, it's self-reported by hospitals, but it doesn't always align with the patient experience. And I think that's understandable to the degree that they're pulling off their EMRs and their scheduling. It may not be aligned with what patients' experiences often are for accessing care. So we're grappling with all this. So any lessons learned from other states would be, greatly appreciated as we try and think about this.
Yeah, I think we're certainly willing to share data, and I can certainly connect Dr. Hammery with our quality team and with the folks here who have grappled that. ED wait times is a big issue for us right now. So we're definitely grappling with that one as we speak.
There were a couple mentions last week as well in the provider meeting about an evaluation plan, and you could think about, you have an all payer claims data set, so looking at where people get care and where different kinds of patients by different payers, different kinds of patients by different clinical settings and or severity are getting care or not getting care, waiting. We've done some measures on like time from diagnosis to surgery for rural patients using claims. So there are definitely ways that you can do it using your all payer claims data set. You probably want to think about which ones you want to prioritize again to not make it too burdensome, but I have some ideas if you want to follow up.
Great. Thank you so much.
Yeah, and I would just offer rural relevant measures. So I know there's some work that we've done in partnership with CMMI over the last couple of years to ensure that, especially with Vermont being rural, that we're using rural relevant measures. And so there is a data set out there, again, happy to share that with you to ensure that we're measuring things that are appropriate for a rural, predominantly rural state.
So appreciate it. Thank you.
Just a couple of very quick reactions. One, I think the biggest risk for a global budget is to do something too stringent, like a fixed global budget. That puts far too much risk, particularly for the smaller hospitals, financial risk for them. On the flip side, in Maryland, some hospitals responded too strongly to the fixed global budget incentives and shifted a lot of care out of the hospital to freestanding centers, and they generated huge surpluses. Which then forced the agency to go in and try to take money out of those hospitals, which is very, very difficult and time-consuming and problematic, and potential legal challenges could result from that type of thing. So the flexible approach moderates volume up or down and covers fixed costs, I think is a much better approach. And with regard to facilities that aren't needed, I think global budgets allow an agency to help transition a facility that perhaps shouldn't be there, an acute care hospital, to something that's more ambulatory based over time. But you can do that gradually so as not to disrupt. I mean, that's the other key rule for rate setting, is make your changes gradual and avoid abrupt disruptions to the delivery system. But you can do that under a rate setting system if you have mandatory payer and hospital participation and the authority over rates and revenues. The last thing with regard to access, which I think is very important, well, the things that I mentioned, that fixed global budgets tend to create incentives to stint on care. So you get high ED wait times, reductions or increases in elective wait times as well. But the rate setting agency in the general category of access is very positive because you could build in amounts to finance uncompensated care in the rate structures of each of the hospitals. So I know the ACA has expanded insurance. We have lower rates of uninsured currently, but there still is uncompensated care, bad debt that hospitals suffer, and rate setting systems can cover those reasonable amounts of bad debt because you have the flexibility through your authority to do that.
Thank you.
Just noticing the time. I wanted to thank everybody for coming. I've learned a lot. I've got a bunch of questions, but I think I'd like to just defer back to the chair so we have time for public comment or anybody else who wants to go, unless we're going to extend past 3.
Let's keep going. I think this is really important
Okay.
and valuable.
Great.
So please.
And I
Great.
just want to say some of our speakers might have a hard stop at 3, so feel free to pop off. But if you don't, we'd love for your continued discussion.
Great. Dr. Harmery, on your slides, I think it was slide 8, had a list of conditions for success. And I wonder if you crosswalk those with the design of the AHEAD model. Does the AHEAD model promote those conditions of success, in your opinion?
It's a great question. The answer so far is no. I've been kind of separate from the AHEAD model. I should have that opportunity in a couple days when they get a technical report out. But you're right, key, and we have noted within the work that have done so far, we're now validating with a bunch of state agencies where those needs are in progress of being met and what additional resource would be needed to speed that up. Because this, as you know, the projection for the AHEAD model is it comes in pretty quickly.
Yeah. So, thank you. That's been my read of it too. This next one I think is for Janice and Bob mostly, but each of you have made statements to the effect that we need to design the program around our objectives, not the other way around. And the problems that we face in our state are rapidly rising commercial prices. We have low utilization rates, and we are a low cost state for Medicare. So if I were to design a program that addressed those 3 things, would I arrive at the AHEAD model? Bob, I see you shaking your head. Janice, Bruce, I see you shaking yours. Janice, your thoughts, please.
So again, that's the challenge at the beginning is what's the path? Because you're right. So what are the levers within it? I don't want to say it is or it isn't, but so how, if you're already a low cost state from Medicare, the question I would ask you is what's the lever to address the commercial aspect within the program? Is there a clear path? There could be that I, don't have enough insight to respond to. So I don't want to give you an answer, but that's where what is the lever that if we enter AHEAD, knowing we're already starting out ahead of, sorry, the pun, but ahead from a Medicare per beneficiary spend, what's the lever that's going to produce the lower commercial rates and how's the methodology going to effectuate that? And is there a clear path there? So to me, if there's not a clear path there, because that's what you're struggling with, then I would say the answer is no. If there is a path there that, yes, we can use this lever to actually reduce, then the answer could be yes. And also, what's the data to show? And I don't know, I can't produce this for Pennsylvania, so I would challenge, what's the data that actually shows a global budget reduces, or that the residents of Vermont or the residents of Maryland that through a global budget actually experienced reduced out-of-pocket spend? Because that's what I hear you stating, is that the issue is, you know, it's the cost that the Vermonters are having to pay, whether that's the employees or the employers, excuse me, the employers through, you know, through funded plans. Like, so what's the connection between a head that's going to actually yield the result of lower cost to the Vermonters? And so I would challenge you to do that exercise. And if that's truly what you're trying to achieve, make sure that you see that pathway versus reacting to a head and saying, well, this is it because it's the only thing we have. Can you see that, and can you achieve your objective within the framework that the AHEAD offers you? And I don't have enough knowledge sitting here today to say yes or no. That's the work that should be done. And then access, are we paying for what are the services that we want? If we have to move towards regional strategies, which I think it might have been Bruce, you know, that showed that, like, so what do we want in every rural community? And if that's what we want, we have to be willing to pay for it. And then what needs to be moved for regional? Also taking into consideration mountainous terrain, winter months, all of the things that you know, having driven through your terrain enough to know, very similar to PA, there's more than just distance and mileage and all of that when we talk about key services. So that would be how I would answer you.
Yeah, thank you. It's yeah, it's a different analytic approach to consider what we need and then design for it versus seeing a model that has some legacy appeal and trying to make it fit our needs.
And also,
Bob?
yeah, and also, sorry, one more point. Sorry. Also take into consideration not the needs tomorrow, but like, you know, as you're looking out 10, 15 years based on most rural communities are aging, you know, what are the needs 10 years from now? And how do we design a system within the new payment paradigm that will support that system versus reacting right now? I feel like there's a lot of us reacting.
I understand. And I appreciate you bringing up the aging portion, because while it is true that Vermont is aging rapidly, right, is it not also true that the absolute number of people who are going to be over 65 is far less than it has been, because boomers, sad to say, they're dying. Generation X is a much smaller group. Millennials are then larger, but there's a big space in there where there are fewer people. And I see Bruce shaking his head. So Bruce, tell me how I'm wrong about that, please.
You're on
muted,
mute,
Bruce.
I'm sorry. I don't think you're wrong about the relative proportions, except that actually the proportions of the advanced elderly over 75, those over 65, are roughly going to double.
Yes,
right?
sir.
Right. And so, and they have pretty intense healthcare needs.
Yes, sir.
So it places a greater demand. I agree with the point that numerically the younger folks are still the majority. But when you think about healthcare costs, as I tried to point out, it's the top of that population pyramid where your costs are really occurring, and the very appropriate population health-based approaches to down at the lower levels to prevent that rise take a long time to pay off, right? Smoking cessation.
Yes.
So
yes, sir. Yes. And I'm not great at math in public, but I'm going to take a stab for a second. If we have 200 people in a region and 50% of those people are over 65, we have 100 people over 65. If we have 100 people in a region because the population has declined and 70% are over 65. It's a higher percentage over 65, but now we have 70 elderly people compared to 100.
Right. And the, let's see, I'm trying to get to my volume numbers here. You're going to have in a population, let's say Rutland, your total population estimated until through 2040 drops from 61,000 to 52,000. But your population of elderly, that is 65 years old and up, goes roughly from 13,000, or a little less than a quarter of the total, to 19,000 out of 52, which is, about 40%, say. So you are seeing, because of the declining population, a large part of that coming from the under 65. You are seeing both an increase in the number and the proportion of people who are going to require more service.
Thank you for that. Bob, I see your hand up, and my next question is actually for you. So maybe we, in a matter of time, I'll ask it and then you can try to tie it together. I'm most familiar with you because of your writing on regulatory capture and policy failure. And so I was wondering if you would comment a little bit more on the complexity of market share adjustments and service line adjustments when it comes to setting global payments, and how that relates to your understanding and what you've written about the risks of policy failure and regulatory capture.
Sure. Let me just quickly address the original issue about the problems you all face there: high prices from the private sector, low utilization rate, lower Medicare costs. I think the high prices issue is, that's, I started out my presentation, that's the primary goal for regulatory agencies, to address that, particularly in the private sector. So the way to do that is through a mandatory system, and that mandatory system requires that all insurers licensed in the state are part of the regulatory model that you set up. That's the model in Maryland. There's an insurance statute that requires every payer to pay the rates that the HSCRC sets. So that's the number one rule right out of the box. With regard to low utilization rates, it's great that you're in that position, but the rate setting system can be structured to recognize that. You're starting out with historical budgets. There's still, I would argue, probably a lot of room that hospitals can focus on to generate lower reductions in unnecessary care. There's a huge volume of literature out there about low value care, and you can structure rate setting incentives to try to direct hospitals to reduce that unnecessary use, and that also improve their operational efficiency. Because I would argue that hospitals in the United States are grossly inefficient. When you look at what MedPAC produces, you compare hospital costs in the United States to hospital costs in other developed countries, we are stratospheric. So there's still room to improve hospital efficiency over time. I think the HEAD program has a tremendous amount of flaws, one being it's not mandatory, two, it won't require all hospitals and all payers to participate, three, it's incredibly complex, a HEAD's not going to get you there. So I would again respectfully recommend that you all design your own model, apply separately to the CMS to get a waiver for Medicare and Medicaid, and then try to structure a rate setting system that deals with the issues and characteristics that are specific to Maryland. Lastly, with regard to capture and failure, I think the issue with regard to regulatory failure, I think William very articulately addressed that, which is the tendency to do too many things because hospitals are complaining and it's a squeaky wheel phenomenon, and then you get a situation the rate setting system is far too complicated. Rate setters need to resist that tendency and focus in on setting, again, simpler systems, broad incentives and targets and goals, and make the system well understood and formula based. That's the way the system in Rochester worked. That's the way the early system in Maryland worked. So I think that's one way to address regulatory failure. Keep it simple and then try to resist the tendency to make arbitrary, politically popular adjustments over time. With regard to capture, I think there are structural features, and I wrote about this, that you can build into your agency, make it more of a public utility type of model. It's very public, have restrictions, have it be very much based on governance through the Administrative Procedures Act in your state or nationally, have it be very transparent, try to a certain extent, isolate the regulatory staff from the influence of the hospitals. I think we're all human. We're all influenced by people that are on our face every day or every week. So you need to have some distance between the regulatory staff and the agency, but otherwise encourage open communication at that public level. That's the way many successful public utilities operate, and that's a good way of avoiding capture.
Thank you, sir. Back to you, Chair Foster. Thank you, everyone.
Maybe we can go another 10 minutes. We do have an afternoon agenda. If Dave or Robin have anything to jump in with.
I just have one sort of additional topic that came up in my mind as we were talking about the number of critical access hospitals we have in Vermont, and the conceptual idea that if we could design the system to deliver the care we wanted to deliver, this is brought up that maybe certain hospitals would do less of certain things. And I think one of the complexities that we have in Vermont right now is that the tertiary hospitals are packed and they can't take more. And what they really want is the smaller hospitals to take those patients. But we don't have like a ring of mid-sized hospitals. We have, Dartmouth and UVM, which are relatively large for our area, but there are definitely community hospitals in the country that are big or bigger than them, but somewhere in that mid-size range that has services that can do that sort of moderate intensity level of care, has ICU capabilities, that has neurologists and cardiologists and a cath lab and surgeons, and that can do the things that a lot of community hospitals do. In Vermont, we have, so if we were to think about rebalancing where services are, we need to make sure that services are somewhere and not just in the 2 academic centers that can't take any more. And anyways, that's something just a reflection. I don't know. I think Bruce was nodding his head, but then went off screen. But I don't know if he had some thoughts on that. But not a question, just more of a comment.
And I would just offer, I think, so you're right. And that's where when you talk about getting rid of beds, and making sure that from a bed capacity, Vermont is right side, but then how do you leverage technology? And is there a way to, do some of this care where the rural community can still do it, but with telehealth connectivity, remote monitoring, some of this to allow the patient to go back to the community for either rehab or even some of how do you leverage the technology? Because even going back to the access question, we can only measure access to primary care and access if we have enough primary care providers, if we have enough mental health providers, if we have enough post-acute care beds. So part of this is ensuring that you have the infrastructure, because the last thing you want to do is hold people accountable for access measures that you don't have the infrastructure. But then how do you leverage technology in the 21st century to make sure? And my issue, even going back to the REH, is there's things that rural community hospitals critical access hospitals are well equipped to do. And we've made it more about inpatient and outpatient, which quite frankly, in my mind, is a payment policy decision, not a clinical care. And how do you develop the system that allows the rural hospitals to provide the care that they can do well and effectively and pay them to do that versus this inpatient versus outpatient. And so again, how do we leverage technology? Technology, the use of this has to be part of, to stretch sparse resources across your state. Technology has to play a big role in that.
I have one question, but Bob, I don't know if you're waiting to go to answer Dave's.
Yeah, I was just going to make a couple of quick comments. Again, I apologize for all this info, but hospitals and those more urban centers are packed largely in part because they're under fee for service, and the incentives related to fee for service are to increase volumes because they generate marginal revenue in excess of marginal costs, and that's one of the ways they increase their profits. If you change the incentives and put those hospitals under a flexible type global budget type of process, you remove that incentive. So you'll see capacity open up once you make the shift in terms of the payment arrangement and incentives. And again, I argue a mandatory model, everybody's in. Those are the most effective structures. Then also I would emphasize this regional aspect of like the Rochester and the Finger Lakes model, where they incorporated their priorities from a health planning and facilities capacity standpoint with the rate setting model itself to try to orient the services within the regions to meet the needs of the population there. Rochester and the Finger Lakes did that very, very well. They coordinated the planning function with the rate setting function so that you had some degree of integrity there. Again, I would highly recommend focusing in on what was organized in Rochester and the Finger Lakes, because I think there's direct applicability to Vermont.
Great. So my question was around focusing transformation and transformation planning, both echoing some of the comments folks have made about ensuring that the pace makes sense for real change, as well as how to incorporate evidence basis into that kind of transformation planning. One of the ideas that has been discussed in a Vermont Medicare global payment methodology would be to have a Vermont specific transformation amount that could be incorporated into that hospital's global budget and connected to a transformation plan. So would love any thoughts you have around that topic.
Well, let me just maybe add to that question, which really is that a number of these activities are underway at various degrees of speed and completion. For example, a statewide health information system. And we have 5 hospitals in Vermont that are linked by the same electronic health record to either the university or Dartmouth. But all the others, the other 8, use different information systems. And talking about ways to advance population health and so forth and so on, that is not an issue which is really within the control of the hospital. So, it's not only focusing attention on the hospitals, but also on assisting some other parts of the healthcare system to get where they need to go. So how have Maryland and Pennsylvania been addressing that?
So I can go first. So certainly within our plan, one of the things that we've utilized is the community health needs assessment. And so, trying to get the needs, and again, each one of those are done with different levels of rigor. But really, as we think about transformation, I would say data informed. And so using community level data, and it doesn't have to be just hospital data or claims-based data. There's other folks out there as we think about like social determinants of health. There's area deprivation indexes. There's other indexes or indices out there that could be used to help identify, but really would encourage you that your transformation planning should be done at the community level. And so I think my question back would be, if you're going to put forth money to help, I think that's a great idea. You've got to give them the investment, but there also has to be some justification for where they're starting and using data to inform at the community level to make sure that they're addressing the most urgent needs. So certainly we started this journey using claims-based data to, we were focusing potentially avoidable utilization. So understanding the claim or the clinical conditions of why folks were presenting to the hospitals to start that. What were the clinical conditions that we were looking to impact through care management strategies? But again, there's other indices outside of just hospital to your question, Bruce, there that should be used to help inform transformation strategies and identify the needs where investment might be needed. And again, at the community level, like I don't think there can be one blanket approach, but flexibility, just like we're talking about flexibility in the budgets at the hospital level, there has to be flexibility for transformation. But yet it should align, in my mind, what are the overall goals of Vermont? What are the overall goals of the Green Mountain Care Board? There should be a map, you know, of the different things that each of the individual hospital communities are undertaking should map up to overarching Vermont goals as well.
Great, thank you. I mean, we are taking the community health needs assessments and a number of the other state reports that deals with specific issues into consideration for the recommendations, but was very interested in how, as you said, in how you incorporate that in a new payment model. So thank you.
Okay. Member Lunch, do you have any other questions? Okay. Seeing the time, oh, go ahead, Carrie.
Sorry, I was just going to add one thing about workforce. I think that if you were going to use some of the, what did you call them? Infrastructure payments or something, transformation payments, at the provider level, one place that might be most helpful is in workforce development. So thinking about what needs to be put together in order to increase workforce across the board, not just physicians in Vermont, and how some of those payments might be used to attract people to providing care here. Sorry, thanks.
No, really important point for us here. So I'm going to take a quick public comment just because I do want to hear feedback on this, and then we'll switch to the next topic. We don't have too much time, but we'll try and do it quickly. Dale Hackett. Hey, Dale, nice to see you back here. How you doing?
Okay. Very good presentation. I really enjoyed listening to this. Can I direct a question to a particular panel member?
Sure.
Okay, Janice, you mentioned Pennsylvania a lot, and I've actually been to Pennsylvania. My granddaughter went to college down there, so I've got an idea of their mountains and how rural they can be. Do you have any idea as far as what they did in the rural community? Was it a mobile service that came in? I mean, you've got populations of only 2,000 people in some of your places. And if you've been up here to Vermont, like you've go to Manchester, Vermont, no matter which way you got to go through the mountains. So winter weather is like, okay, I can't put a hospital anywhere else and really call that reliable healthcare. If I gotta get the people out, I need something in the town. So, and you said you came from a manufacturing background as well. That distribution is really important. But are we talking just buildings, or are we talking? I mean, Canada uses helicopters at one point, because you got 9% of the population within 150, 200 miles of the border. Any thoughts on that?
Yeah, so thank you for the question, because, you know, talking about the infrastructure is really important. And to your question, we haven't gotten to mobile solutions yet as part of our current program, but thinking as part of a next generation. So again, we're putting pen to paper of what comes next. Is we know mobile solutions have to be there because there are more cost-effective ways to provide service. We think, you know, mobile integrated health, mobile services definitely can be part of it. We've got some regulatory hurdles to get over in the state of Pennsylvania. But again, would challenge this, you know, what's needed in terms of payment policy reform, you know, EMS. You know, not only do we have a workforce shortage, but, you know, limitations of what currently EMS can be doing, you know, mobile integrated health strategies of how do you use some of these clinical personnel in the rural community to maybe, you know, do more than just transport people to a hospital. How do you use alternative types of care providers to take the care to the rural community? So no, it's not just hospitals. But I think that as we think about the future and the technology that we have, you know, I have an animated slide that I also like to use to kind of cast a vision for mobile integrated health. And how do you use these types of strategies within alternative payment? Again, because the hospital within an alternative payment is incentivized different And so, you know, bringing that patient to the hospital is not necessarily what's needed anymore, but can you train the EMS to give the aspirin of the Medicaid patient that calls the EMS because that's the only transportation they have? So how do we rethink and move forward using what technology we have to think of care outside the walls of the hospital, even hospital at home concepts? What types of care, infusions, all of that can be done safely in the home if we had the workforce, as has already been talked about here. If we had the workforce, how do you truly reinvent the rural health delivery system? And again, we are trying to piecemeal everything onto a very broken fee-for-service system. And we truly need to try to rethink. And if we have the opportunity through some of these new payment models to truly rethink the future, what do we want to build? Knowing it's going to take time. None of this is going to be done tomorrow, but what's the system that we want to use? Again, getting to your point, the delivery system, the infrastructure, all of that, the pipeline. There's other ways to do things, but we have to think differently, and we always compare to what we have. And that's the new mindset. One of my colleagues said earlier on this call, it requires a new mindset, and it absolutely does.
Thank
So
you.
hopefully that was helpful, Dale. I think that was you, Dale.
All right, Ham, you went over this morning, so let's see how we do this afternoon. You ready?
I'm gonna be really good this afternoon, Mr. Chairman.
Right.
Let me start out this way. I've watched these since 1987, okay? And today, this is the metaphor I'm going to use for what you've done today is to say that we've spent the last 30 years sort of what if we were baseball guys, we'd be watching the Pony League in Northern Idaho, and all of a sudden, oh my God, here we are, and we're in Yankee Stadium. So we've got national class players, and I think we have you to thank for that. Having said that, I like to make two basic comments. One is that I think that one of the things that worries me about listening to the guys in Yankee Stadium is that they keep talking about the hospitals, and I believe that Vermont is not the hospitals. The Vermont is two dramatically different hospital systems. 3 of the hospitals have got 60% of the care, and of that, that's mostly UVM, and 11 have 40%. So the question, so I just think that you just really have got to start breaking the thing into two hunks, because there's no resemblance between any of the 8 critical access hospitals and a 500-bed academic medical center. And just so just 3 comments. These are not questions because there are time to really eat it up all the time. Here's what I would suggest. We've got Dr. Murray here from Maryland. Okay, let me just suggest something about it. I know a lot about Maryland. I live there. Okay, I've been in hospitals in places like Annapolis and Silver Spring. Okay, here's what I suggest, and here's what I would ask him if I was talking to him. You can do all kinds of things in Maryland, okay, with hospitals, but let me suggest something I would bet real money you can't do. If you want to do something in the regulatory structure in Maryland that the doctors in Johns Hopkins think is really terrible, you are dead meat. That's just a suggested thought, okay? It's the kind of question I would ask Dr. Hammery about his work with Geisinger. I've read his work in your archives 10 times. It's very impressive, okay? But here's what I would ask him. I can't remember the numbers exactly, but if you look at Geisinger, it's at least some multiple, maybe as much as 5 or even more, the size of the whole state of Vermont. Geisinger, this is the Geisinger service area. Is it 5 or 9? Can I just ask him that? How much bigger is Geisinger? Number. Okay, never mind.
Well, the population about 3 times, service area about the same.
How about what is the that my point is, what is the geographic acreage or square mileage of the service area?
So
I think it's
why don't we do
The
this?
reason
roughly
why- the
27, yeah,
reason why-
roughly
So let me-
27,000.
I'm almost.
Let me just
done,
interrupt.
Mr.
We're getting,
Chairman.
hey, I'm sorry, we're way over. So if there's, you can just send some questions and we can try and get back, but I got to get
That's
to
the question.
Shuley and the
So,
others.
The other thing, and this is for you, Mr. Chairman, you, in the hearing we did the other day, you waived off the question of whether some use, when volume were age adjusted. Here's just a gratuitous suggestion. Talk to Ms. Cola, okay, and to probably Hamri, okay, and they will tell you that if your data is not age adjusted, it's not worth having. I'm done.
All right, and just for the record, I think you started over on your count of number of comments. I'm just noting. All right, Eric Schulteis.
I promise I will try to keep this brief, Chair Foster. So I think one of the things I heard that was missing from the stakeholders of this new process of system transformation is the voice of Vermonters. I think if we just look to quasi-recent history, some of the political disillusionment and maybe fact twisting to some extent on all party sides about what's happened in the last 6 years has been due to a lack of engagement and understanding and hearing Vermonters' voices. I think we can also look to say what happened in urban renewal, what happens when we have a purely top-down, technocratic-driven solution, right? It doesn't work. Someone gets hurt. I think fundamentally, we need to develop a shared truth amongst the various actors. So just thinking about community benefit or free care, Vermont hospitals book compared to peers, and I'm confident in saying this is a preliminary analysis of 5 years of national 990 data. Vermont hospitals book more unreimbursed Medicaid than their peers. That's despite Vermont having one of the best Medicaid reimbursement rates in the country, and despite the fact that Vermont payer mix is better. And until we address some of these shared beliefs and what actually is a benefit to the community, I don't think we can start moving forward because the different stakeholders have different views. And lastly, just about access, I think spatial access and spatial optimization is one dimension of access, but there are other components. So traveling 15 minutes for me for a doctor's appointment, no problem. I tell my boss I'm using sick time, I click out, but the person who's working 3 jobs doesn't have sick time, can't do that. So I'm just thinking back to you, Dr. Hamri, for some reason, the example of a hospital CEO saying all Vermonters have snowplows. That stuck with me, right? So what is the effect of organizational beliefs like that on patients? And sure, it's easier to measure who's used a service, right? Realize access, but how do we measure and understand why people who could use a service, why don't they use the service? And even the question with utilization, sure, one, you want to have checks. You don't want to see utilization dropping precipitously. But there's a question of who is utilizing the service. Is it the people we care about, or is it just the wealthy people above, say, 800 FPL? That should concern us. And I think we have to have complex understandings of what access is and shared truths about how the system functions and should functions before we talk about payment reform, because payment reform alone without these shared truths is never going to solve the problem. Thank you.
And my favorite voice of Vermonters, Walter Carpenter.
Hey, Owen. Thanks for the
Hey.
kudos. Favorite voice. I do if I had a wish, I could coin a Walter Medal to all 5 members of the Green Mountain Care Board for having to sit through meetings like this, discussing models. They've been through about 10,000 of these meetings on 10,000 different models. And I just have a couple comments, really, no real questions. As I listen to all the experts and everything and all the talk about hospital, this and that, one of the things I want to say is, where is the patient in that? And I think one of the biggest and most horrible things we do in this healthcare, in our healthcare non-system, which it really is that we treat the patient as a consumer. And in all of these presentations, it sounds like I'm sitting in a Harvard Business School class, or a school at Babson where my father was a teacher, or a professor rather, listening to how to run market share and all that. Healthcare is not about that. I was a patient. I know what it's like to go through a system where profit is the motive and where operating revenue or margins and all that. I just had a friend who broke her hip, kicked out of the hospital after a 1-day stay, not even a day after they fixed her up, they just threw her out. I had to go get her. A healthcare system is about patients. When I hear talks about utilization, it kind of fires me up, because that's what the damn system's for, is to be utilized. So I'll be quiet there because I know Owen wants to get going.
Thank you, Walter. Thanks for coming as always. One
I
last one.
had to work the last 2 weeks.
Oh,
Yeah.
well, come by and try and say hi sometime. Last one, we have a hand up from guest.
Hi there, can you hear me?
Yes.
Hi, Robert Hoffman calling in. I'll frame this up. I'll do my best to be brief. I know I haven't been in the past, but I'll frame it up by recalling a session with Dr. Kala back in 2019. She threw up the public health crisis of gun violence, gun mortality, and was leading a class on that. And we're talking about an intervention. So the problem was gun mortality, and how do we solve it? We threw up all the solutions that have been tried and available, and each of us broke out in MBA form to try and solve it. And the class all returned to the known variables of how to solve gun violence. And just like the last 7 years, we have data to show what the contributions of capitation have been to the state of Vermont. Similarly, when it came to gun violence, there wasn't really that much progress made. And what I proposed at that time was stratified by mortality. Most of the mortality is related to under 23 years of age, Black and Latino males committing firearm violence. And the other major population is stratified by is middle-aged white males committing suicide. And then can we look at tax credits to solve for how do we get guns? How do we incentivize guns being taken out of those communities? It was an out-of-box idea, but at the time, Dr. Collis said it was a good one. I want to encourage you all to similarly think about your problem ahead of you. Your problem is not containing costs. You've done a good job of that, and Medicare's told you that. Ahead, we'll continue to solve for that problem. Walter asked a moment ago, where's the patient in all this? For years, I've sent you all, and I believe I even sent it to Dr. Kala at one time asking if she was interested in it. Vermont has had materially significant declines in health outcomes since capitation was introduced, concurrent to hospital insolvency and declining access. And moreover, based on the data that I pulled across the measures for which this state is supposed to be measured, there's been, as a result of capitation, and no specific actor here, but just the state applying itself to a CMMI experiment involving capitation. There's been an excess of mortality in 18 to 65-year-olds across measures that the state's supposed to be monitoring. So what I would encourage you all to do is to the question of, do we miss out if we don't participate in the head because we're going to miss out on some X millions of dollars in transformation funds? That's poverty of imagination. You have a lot of options available to you, and you have a lot of smart people on this call and a lot of smart people on your team. I'd strongly encourage you all to utilize the collective imagination you have to come up with solutions, and quickly. And I guess I'll just put one last plug in. By 2030, we could already be seeing the entire transformation landscape changed. If you're unaware, Medicare just adopted policies to start reimbursing for weight loss medications that are already causing dialysis makers to have their stocks bottom out. Transformation's happening all around us, and there's going to be people that are going to be beating us to it. And some projections predict that very meaningful percentage of the population that's driving these costs that you're trying to solve for are not even going to be there for you to solve for in a decade. So one of your commenters mentioned, what are you building towards in 10 years? You have a really, really ambitious plan to try and do things here, but you got to also calibrate it to where's it going to land you in 10 years? And you're locking yourself into potentially a model that's going to last 10 years. And it's going to leave legacy level institutions, and to Member Walsh's point, possible of creating regulatory capture, of creating massive second order effects that, as with all payer, you weren't able to anticipate, much more profound likely with the complexity of this model, which is makes the APM look comparatively simple. So I just want to bring it back to Walter. You know, these decisions are life and death ones. And we all get to go home after a meeting like today and feel excited about all the discussion and use of policy lingo that we love using. And the reality is these decisions are going to have lasting effects on people's lives, many of them just like Walter. And so I strongly enjoin you all to hear his voice and the many others who haven't really volunteered to entrust your lives to them, but by virtue of them being your constituents as part of this administration, you're making life and death decisions for them. Thank you.
Thank you for chiming in with your thoughts, Mr. Hoffman. I'd like to end it there and take a 5-minute break before we go to our next one. I apologize to Elena and Shule for being a little over, but I thought this was really productive and important. And I wanted to really thank Elena for putting this together, and for Carrie, William, Bob, Bruce, and Janice for being so generous with your time. I know all of us board members had this date circled on our calendar for good reason, and it didn't disappoint. We wanted all these diverse views to kind of help us think about these problems, and you really helped us do that. So I hadn't met all of you, but it was nice to in this setting, and thanks for your generosity in helping Vermont with this. We'll take a 5-minute break and come back for the next presentation. Thank you, everyone.
Thank you for the invitation.
Thanks for having us. I was happy to learn from you all as well.
Hey, Shule, how you doing?
Good, how are you?
Well, sorry, we are massively over.
No problem, no problem at all. I can stay as long as you need me, but I wanted to ask how much time would you like to allocate, given where we are?
Let me, if I send you an email while we go, can you read it?
Sure.
I just want to check with folks. I'll send you a little message.
Okay.
Okay, so we'll resume our hearing and turn it over to Elena Misgarovich for the AHEAD presentation.
Great, and we will breeze through these. And Michelle, thank you for running the slides. I'll just very briefly talk about the schedule, where we are in the schedule, and then pass it over so we can get moving. So we'll walk through the methods paper, the draft one. Today, Shule Garovich will walk us through that. And then we're going to post the methodology, the draft paper itself. We hoped yesterday, but we're still tweaking a little bit. So our hope is to post it tomorrow. We'll still extend the public comment period accordingly, and then continue discussion and come back to kind of how we want to think about the board vote at the end of this conversation. So hopefully you've had time to think about what we introduced to you last time we talked about the Medicare hospital global budget specification and methodology. So I will turn it over to Shule. Thank you.
All right, good afternoon, everyone. And I caught the end of the prior discussion. It's been great discussion so far. So we are going to go back to the details around the financial methodology. So we wanted to start with the kind of requirements that the CMS has under the AHEAD model. Given the time, maybe I won't go through all of them, but highlight the ones that are kind of important to keep in mind. So if you advance to the next slide, that will be great. In general, this is starting with the hospital, right? So the minimum requirement is to have hospital inpatient, outpatient services, but they do recognize that the critical access hospitals would have additional adjustments under this model. TCOC, so total cost of care adjustment, is a requirement as part of this CMS notification. Next slide, please. The other requirements, the social risk is a big one that is new, that hasn't been done in Maryland or Pennsylvania, and that there's also considerations for early recruitment of the hospitals and create incentives so hospitals join early could benefit from the program more. Next slide, please. Quality is a component. So as you know, hospital payments in the Medicare program are already adjusted for quality. The requirement is that the state designated methodology should also have hospital level quality performance in the methodology. Next slide, please. We already mentioned the accountability for total cost of care. The number 8 is, I think, very important to remember. Reflecting on some of the conversations around fixed versus flexible budget, the CMS is requiring the state methodology to adjust the budget based on service line changes and shifts between providers. So the idea here that to balance the incentives around doing more utilization to increase the volume and revenue under fee-for-service versus the unintended consequences of the fixed payment where hospitals may reduce access or shut down their services. And the number 10 is kind of thinking through the critical access hospitals or safety net hospitals that they are requiring the critical access hospitals to move away from cost-based reimbursement. But they are allowing the methodology to do additional adjustment to reflect the cost. All right, am I going too fast? Should I slow down a little bit? Okay, good. So as Elena mentioned, the current methodology methods paper, we call it, is a version 1. There are still some details that need to be worked out, but we also are expecting public feedback, additional board feedback, as well as the CMS feedback to call this as a final version. But keep in mind that these methodologies kind of change over time. So I expect that over time, there will be additional considerations, and we try to summarize that in the next couple of slides. Next slide, please. So we'll just run down each adjustment or each decision and give you a comparison of what is in the ahead, if we made changes for the Vermont specific methods and future considerations and rationale. So we, as we go through it, I'll do my best to explain the rationale. So the first one is eligible facilities. So AHEAD requires at minimum acute care hospitals. We did not make any changes in the methodology to that eligibility criteria. There have been discussions about expanding into specialty hospitals. So that could be potentially a future consideration for the Vermont model. The second one is about included and excluded services in the AHEAD model. It includes only hospital Part A inpatient and outpatient departments. And then there are a series of exclusions that we had discussed extensively in prior meetings. So we are kind of using the exclusion criteria from the AHEAD, and there needs to be additional conversation with CMS around how to handle the blueprint, SASH, and CHD payments that the CMS currently provides to Vermont. In terms of future considerations, professional services was designated as a high priority during our stakeholder engagement process last year. So that will be the priority to work to include in the global payment methodology. So this includes professionals who are employed by the hospitals or have delegated their billing authority to hospitals. And also the other services that are owned by hospitals, such as clinics, rural health clinics, or skilled nursing facilities could potentially be added to this model in future years. And the reason why we accepted the exclusions is to concern around the access. So these are high cost patients or high intensive high cost drugs type of services. So excluding them is going to kind of protect the access or reduce the concerns around unintended consequences. The reason why we couldn't include physician was mainly due to data issues and methodology that we needed more time to verify and figure out how to collect that data on the Medicare side. And the last one is as the baseline calculations, as it was brought up, we are using historical payment amounts to calculate the baseline revenues. So we will be using 3-year weighted average, similar to the AHEAD model, but we are making a modification that if the last year of the baseline is higher than the average, we will take that higher amount. And the reason for that is to avoid that drop in the revenue in the first year of the program if they already are at a higher level in the last year in the baseline. All right, so I will go to the next ones. There is a language to allow exception-based factors, so these could be ad hoc. So we are taking that concept as well from the CMS methodology, but in the Vermont specifications, we added additional considerations such as the impact on overall state target, commercial payment rates, and these will be approved by the CMS, but it's also require CMS approval per the CMS regulations. So currently there is no future consideration, but it may evolve over time as we get more experience in what those exception-based factors might be. And the reason why we have this, as you all know, we cannot predict everything. The pandemic happened in the midst of the Pennsylvania rural health model that they need to work through additional adjustments, for example. So having a language and understanding that there might be situations where additional adjustments will be made is important to have in the methodology. Sequestration is kind of a general 2% adjustment downward done in all provider payments in Medicare. It's a statutorily required adjustment, so we do not have flexibility. So we will be applying the HED methodology in the state model. And next slide, please. Moving on to the baseline incentives, the first one is the transformation incentive. This is in the CMS methodology as 1% for the first 2 years. We chose to take that adjustment as it is, but in the future, we may need to consider additional incentives for the transformation. What we have different from the AHEAD is the Vermont Health Delivery Reform Investment, where the Vermont methodology is creating a pool of funding that will be available to hospitals for a number of years to support healthcare delivery reform in the state. And rationale for having this is, as has been discussed, Vermont has a low-cost Medicare state, low utilization rates, and access issues, that this additional funding is needed to support investments, not only on the hospital field, but in the non-hospital provider space as well. We created the pool as opposed to adjusting global budgets similar to the transformation incentive, because we recognize that the Act 167 and other, like, it's going to be very local, so it requires additional review process or application process to balance available pool with the needs that the community would put forward through this investment program. And I say by we, so I think I did that in the last one. We appreciate the stakeholder feedback, the staff. So I'm using Royal V here, that this is truly a collaborative effort with the staff, board members involved, your feedback, as well as the stakeholder. So I just wanted to make that clear as well. Next slide, please. All right, so we have set of other adjustments. So as we created the baselines and incentives, annual updates, inflation update, CMS is using market basket minus the productivity adjustment. In Vermont version, we are only using market basket adjustment, and the intention is that we would do an efficiency effectiveness adjustment on an all-payer basis that will be designed and implemented at a later stage. The demographic changes, so these are the beneficiary changes happening in the traditional Medicare. In the AHEAD model, the adjustments are done on age, HCC, which is the risk score that CMS uses, and the population growth, and then they do a correction at the end of the period to adjust it using the observed beneficiary trends. Instead of using population growth, Vermont methodology is going to use the actual beneficiary change, and the adjustments will be based on age, sex, and ESRD. The future consideration here is HCC adjustment. So this is the risk adjustment. We chose not to have the HCC adjustment initially for multiple reasons. So the first one is demographic adjustment is already capturing a large variation in hospital cost. HCC adjustments are actually on the total cost, not just hospital. So there is that mismatch of methodology if you are trying to predict the hospital cost. Second, CMS is currently transitioning the way that the risk adjustment scores are calculated, so methodology change. And in the next 3 years, the change in HCC scores may reflect the methodology itself, not the risk profile of the Vermont residents. So we didn't want to have that additional uncertainty in that initial years, but we would be monitoring and potentially including HCC adjustment in future years. And in addition to HCC adjustment, I will go to the social risk adjustment. So this is additional 2%, up to 2% funding for providers who are serving the underserved areas. And in the CMS methodology, they create an index using area deprivation index, a proportion of Medicare, Medicaid dually eligible, or those who are eligible for Part D low income status, to create a hospital social risk factor. For Vermont, the methodology will use social vulnerability index, and it will also use the dual eligible, which is the Medicaid as well. We modeled some of the SVI and ADI and provided additional information in the past. I'm happy to go into the detail if there are any questions. But basically, SVI is chosen based on the feedback from the stakeholders, and mainly ADI seem to be looking at a very small geographies and giving the population in Vermont, the rates seem to be fluctuating and not as accurate as the SVI. And one additional change that Vermont methodology is going to have is this score will be calculated every 3 to 5 years. CMS methodology is updating it every year. Based on our initial modeling, we didn't see much change year over year. So this also reduces the uncertainty. So hospitals who score the highest will get that funding for the first 3 years. We'll recalculate the scores. If there are major changes, then their payment will be adjusted accordingly. Medicare policy updates. So these are additional payments the Medicare pays for medical education, uncompensated care. The Vermont methodology is applying the ahead, so no changes there. And the reason why there are no additional adjustment is to maintain the benefit of these adjustments for Vermont hospitals, so that they are not losing any of these additional adjustments or policy changes in the future by participating in the global payment program. Next slide, please. The final set of adjustments are on quality and performance. As I mentioned, CMS requires the quality adjustments, and they are using their current various hospital quality programs. In the Vermont methodology, we are working towards creating a simpler approach to account for these adjustments, but mainly taking those scores initially. And the future consideration for Vermont is to develop an all-payer hospital quality program and replace all the CMS adjustments under global payment. The critical access hospitals are required to report, and then will be receiving additional payment based on their performance in future years in the CMS methodology. Vermont methods are adapting that concept, but we would like to assess the feasibility of these additional measures, because given the small number of utilization and cost, some of these measures may not be valid or not usable. So there needs to be additional assessment.